distinguished guests, speakers, delegates, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. The Honorable, the President of ASEAN Congress of Neurological Surgeon, Professor Yoko Kato, MD, PhD. The Honorable, the President of Indonesian Neurosurgical Society, Professor Abdul Hafid Bajarnal, MD, PhD. The Honorable Vice Rector of Mataram University, Mr. Agustin S.A., MBA, DBA. The Honorable, the Chairman of the Committee, Dr. Rahadi, PhD. And also, professors, doctors, all speakers, ladies and gentlemen, we love. Distinguished guests, speakers, delegates, ladies and gentlemen, thank you very much for your coming on the third day of Second ASEAN Congress of Neurological Surgeons. Before we move on to the next agenda, let's take a moment of silence to pray and this event can run smoothly. Pray, start. Thank you. And now we will be entering the first session of this event, plenary lecture with Dr. Asra Al-Fauzi as a moderator. Before I hand over the session to Dr. Asra, please allow me to read his CV. Dr. Asra Al-Fauzi was completed his medical studies at Udayana University in 1994. In 2001, he was completed his management studies at Terbuka University. He continued his master studies at Erlangga University and graduated as neurosurgery specialist in 2007. In 2008, he was completed his postgraduate neurosurgical training at Shinsu University, Japan. He continued his doctoral studies in medical science at Erlangga University and graduated in 2015. He was completed his master management studies at Ciputra University in 2017. That is the short CV from Dr. Asra. And now I hand over the session to Dr. Asra. Time is yours.
Okay, good morning, ladies and gentlemen. Thank you very much for this opportunity to moderate this session. Welcome you all to this third session of plenary lecture session in this ACNS program. And this session, we will have 4 extraordinary speakers, I think. I think we all have to listen and watch of their talk in this session. It might be very important. And the first speaker will be Professor Charlie Teo from Australia. I think we already know him quite well, so I will not introduce him completely, but we know together that he is very leading expert in minimally invasive neurosurgery, and also he was expert, in advances and researches about the techniques and technology in brain tumor surgery. So I think Professor Charlie Teo is already here now. Please, Professor Teo, time is yours. You can start your presentation. Thank you.
Thank you very much. It's again a pleasure to be here, and thank you for the very kind introduction. My job this morning is to talk about a very controversial subject. It is the subject of pineal cysts. And I think if you looked at almost every textbook on pineal region tumours or pineal region pathology, they'll tell you that pineal cysts are asymptomatic and never require surgery. If you go to conferences where they talk about pineal tumours, there's always some little section on pineal cysts that reiterates that pineal cysts are never symptomatic and never need surgery. Well, I didn't quite believe that. And almost 35 years ago, I started operating on the occasional pineal cyst patient who I felt had genuine symptoms and signs and MRI findings. And I've been continuing that practice of offering surgery to patients with pineal cysts now for almost 4 decades. And we've published our results showing very good outcomes on these patients. So I'd like to now relate my experience with pineal cysts to you, and hopefully you'll learn from this presentation that in fact there is a subset of patients who will benefit tremendously from surgery for this condition. So what are pineal cysts? Well, they're glial cysts of the pineal gland. They occur in about 1% of the population. They rarely change in size, although we have documented some cysts that have got bigger over time, such as this one from 8.5 millimeters to 14 millimeters over a period of a couple of years. And they've also been known to shrink in size. Here's a pineal cyst that was symptomatic, and clearly the patient had some sort of hemorrhage or apoplectic event, and it shriveled up and it was much smaller. And this patient's symptoms actually resolved after this hemorrhage. Here's another case of apoplexy or hemorrhage into the pineal cyst with a fluid level. And they can present in many different ways. Of course, they can present as incidental findings, but when they do have symptoms, they usually have headache, sensory disturbance, which is often hemisensory, visual disturbance, which can be anything from seeing a halo around a light, or double vision, or visual obscuration, blindness, loss of vision. And then, of course, there are many unusual symptoms of the pineal region, such as sleep disturbance. And I'd like to also underscore the fact that many of these patients have functional overlay. Now, what does that mean? These people have been told for years by multiple practitioners that their symptoms have nothing to do with their cyst, and yet they know that something is wrong. So they tend to exaggerate their symptoms. They come in with long lists of their symptoms. And we tend to classify or compartmentalize these patients into the two-part basket. We say they're all a little bit crazy because they do. They become a little bit crazy because no one believes that they've got symptoms. How else can a pineal cyst present? Well, if you look at the literature, there are multiple cases of patients with pineal cysts who have died from hemorrhage into the cyst or sudden death, not dissimilar to the sudden deaths that you can experience from a colloid cyst obstructing the CSF pathways. So it's not just 1 or 2 cases, there are multiple cases of sudden death pineal cysts. So it does happen, it can happen. How do we manage pineal cysts? Well, currently, if they come into your clinic with an incidental finding and are completely asymptomatic, then of course, no surgery, no treatment. Conversely, if they come into your clinic and they have clear signs of raised intracranial pressure, they have secondary hydrocephalus, or they have a Paranose syndrome with compression of the tectal plate, then of course that patient will be offered surgery. This is a group of patients that I think we struggle with now. The patient who doesn't have secondary hydrocephalus, they don't have signs or symptoms of local compression, such as Paranose syndrome, but they definitely have symptoms which can include headache, and it may not include a headache, but they have neurological symptoms and a pineal cyst. This is a big question mark. Now, isn't it funny that when you see pathology in the pineal region that is non-cystic, in other words, a small tumor, or maybe an arachnoid cyst, any sort of tumor in the pineal region, we believe can cause compression of the aqueduct and subsequently they present with headache. However, if patients come in with a pineal cyst that's of a similar size or even bigger, we say they can't have symptoms. Now that to me is a little bit strange, and I've got some great examples of that. Here's a patient with a tumor in the pineal region who presented with headache. Here's a patient with a cyst of exactly the same size, and the same doctor saw this patient and said, this tumor is causing headache, but the same doctor who saw this patient said the cyst can't cause a headache. And here's 4 cases. Here are all tumors. Tumor, 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 and tumor, all causing headaches. And yet these cysts that are clearly bigger than these tumours, all the doctors say can't cause headaches. Is a arachnoid cyst. So this is arachnoid cyst of the tectal plate. This young girl came in with clear symptoms and signs of compression, and you can actually see the compression right here. We take the cyst out, she gets better. And yet we still don't believe that a pineal cyst of the same size can cause symptoms. Now, there's something a little bit ironical and paradoxical about that. Here are the articles that we published. This first article was published in 2015, a small number of patients showing excellent outcomes. Another article out of Europe, another article out of Russia, another article out of Germany, and all these studies showed exactly the same thing. In a select group of patients with headache and a pineal cyst, in the absence of neurological deficits and ventricular megaly, surgical treatment of the cyst will eliminate the headache and reduce many of the other symptoms in almost every patient. Now I'm not talking about an efficacy rate of 50% or 60%. If you look at all those studies, you're looking at an efficacy rate of greater than 90% in all those studies. So this is a very effective operation for the majority of patients. So here's our data. Almost 100 patients, most of them had headache, more females than males, age range about 7 to 57, so they're young to middle age. Average length of time from onset to surgery, and this is quite worrying. And these poor people have had symptoms for years before they present for surgery. All of them had a complete surgical resection, and here's a breakdown of symptoms before surgery. So these are just Venn diagrams showing that most of them had headache. Other symptoms include photophobia, nausea, vomiting, sonophobia, dizziness, poor sleep, visual disturbance, memory disturbance, tinnitus, and syncope. And syncope can be, where there's loss of consciousness, well documented, but no apparent seizures and no tonic-clonic movements. In my experience, I've tried to be very selective about the patients on whom we operate. The headache, I would like it to have some sort of feature of raised intracranial pressure or intermittent raised intracranial pressure. I insist that they have seen a neurologist and have been comprehensively evaluated to make sure there's no other cause for the headache. And I like the imaging to show me some degree of compression of the underlying aqueduct. And here's some examples of preoperative imaging. Pineal cyst, clear compression of the aqueduct. And if you expand that, you'll see that the aqueduct is clearly compressed in its proximal portion. Once we saw all those criteria, we offered them surgery. All patients had an open endoscopic assisted resection. None of them had a pure endoscopic resection. The first 5 patients, I used to take out the entire pineal gland, but 2 of those patients had postoperative sleep disturbance from lack of melatonin. So after the first 5 patients, since then, we've been leaving a little bit of the pineal gland left behind so that they can maintain their melatonin secretion. We adopt an either supratentorial or infratentorial approach, depending on the long axis of the cyst. How do we choose? Well, if you look at the long axis of this cyst, it takes you supratentorial. So this, we choose an occipital, transtentorial, retrosplenial approach for this cyst. This cyst, if you look at the long axis of this one, clearly this is a supracerebellar infratentorial approach, or what we abbreviate as the SCIT approach. This is how we position the patients. It's a supine, head turned contralateral. The incision is a paramedian incision about 2 finger breadths away from the midline, where the craniotomy can blue line the inferior border of the transverse sinus. Preoperative and intraoperative foramen stereotactic guidance, minimal hair shave, small craniotomy, burr hole, so that you can blue line or see the inferior border of the transverse sinus. Here's a small video. Maybe it's not going to show. Can't play. Don't worry, I can play that for you later if we have time. This is positioning for the occipital interhemispheric approach, prone, head in the neutral position, paramedian incision, wide opening of the tent. This is a small video of that approach. Just to orientate you, this is a top, this is a bottom, this is a right side, right occipital lobe, dural flap. Underneath the dural flap is the superior sagittal sinus. Interhemispheric approach, opening up the CSF spaces, identifying the straight sinus and making an incision in the tent about 1 centimetre away from the straight sinus so that you don't open it. Always making sure that you're not too close to the entrance of the vein of Galen into the straight sinus. Wide opening, coagulation. Here's the straight sinus. Here's the free edge of the tent. We're going to complete the opening here. No fixed retraction on the occipital lobe. This is the splenium of the corpus callosum. Coagulation and cutting. Here's the dense arachnoid of the pineal region. We're going to open those arachnoid. Find the cyst. And as is my usual practice, we try and maintain the integrity of the cyst to go around its borders, coagulating, cutting, sharp dissection, maintaining the integrity of the large veins, and then total resection of the cyst, including about half to 60 to 70% of the pineal gland as well, but always leaving a little bit of pineal gland behind to maintain the melatonin levels. No fixed retraction of the occipital lobe. Endoscopic assistance to make sure that we get a good resection. What you see here is the tectal plate, back of the third ventricle. So that's a central vein. Here's the back of the third tectal plate here. And again, we're just looking around to make sure that we've got all the cyst out and a significant portion of the pineal gland as well. Okay, here's the results. Now, again, you're just going to have to believe me. A lot of people don't believe the results, including myself. So we had 7 independent people assessing the results to make sure that they were true, and it's pretty remarkable. We're looking at almost 100% success rate with these patients. So we've had 1 patient with symptomatic recurrence, no recurrence of the cyst, but recurrence of the symptoms. Mean follow-up, about 4.5 years. We've had 19 postoperative complications, of which only 2 have been permanent, and 2 permanent patients with disconjugate eye movements. Double vision, incision pain, post-op sleep disturbance, they're the major complications. And these have now been, we reported them in the literature. This is an interesting paper which talked about the improvement in the size of the aqueduct after taking out a cyst. And we've seen the same thing. It's subtle, but it's real. Pre-operative showing a little bit of obstruction, post-operative showing opening up. Now it's subtle, but it's real. And again, we can show you multiple patients with this improvement. Small cyst, subtle stenosis, much wider after surgery. And again, you can see it here, small cyst, subtle stenosis, much wider after surgery. And that one's more obvious. And we can keep showing you these these cases of improvement in the size of the aqueduct after surgery with happy patients. This is interesting. These are two patients who had a delayed positive response to surgery. So in other words, they came back and saw us at the routine 6 weeks post-op visit and still had some symptoms. We did the scan, showed the cyst was gone, but the aqueduct had not opened up. They come back 6 months later, they have complete resolution of their symptoms and the aqueduct has opened widely. So let me warn you that sometimes in these patients, they've had chronic stenosis of their aqueduct, and that needs a bit of time to open up. And here's the other patient that had the same thing. Preoperative cyst showing stenosis, postoperative cyst gone, but still stenotic aqueduct, and still with symptoms. 6 months later, aqueduct opens up, happy patient. So sometimes there can be a delay in clinical and radiological improvement after cyst excision. And finally, I'd like to make sure that you understand that this surgery has huge positive consequences on these patients. They really do get significant improvement, not only in their headache, but many of the other symptoms as well. And they often, it's this recurring sort of result where they say, thank you for giving me my life back. So the symptoms of pineal cyst can be really quite debilitating, where they have a negative impact on their work life, their social life. They no longer do things that they used to be able to do. And then when you take the cyst out, it's like their whole world has changed. And oftentimes they come back and say, thank you for giving me my life back. And even though most of the patients, you know, seem a little bit crazy, I mean, most of them aren't. And this is a patient who was a doctor from Florida, came out to Sydney for his surgery, straight shooting sort of guy, didn't embellish his symptoms. He was just terrible before surgery and completely normal after surgery. So I need to leave some time for questions. I think we're unfortunately running out of time. So we've only got 8 minutes. So look, I'll conclude by saying that in a select group of patients, headache and other neurological symptoms may be improved by resection of a pineal cyst, even if they don't have hydrocephalus. The surgery is very safe. Symptomatic recurrence is rare. We've only had one patient who've had recurrence of the symptoms and they did not have recurrence of the cyst. I would recommend an incomplete resection of the pineal gland because then you won't get patients with sleep disturbance after surgery. Thank you.
Okay, thank you, Professor Theo. Very extraordinary presentation, and you make a new paradigm how we neurosurgeon treat this pineal cyst. Yes, as we know that sometimes we treat this patient with conservative management because with mild symptoms. So I hope there will be a question. Yes, this is one question from Dito. Yes, he's a resident from Surabaya. What is the goal treatment of your pineal radial tumor patient? Would you mind to share us how to treat from the preoperative to the ward management, pitfall of them? Thank you very much.
Okay, so firstly, there are many different causes of headache in people. And since 1% of the population have a pineal cyst, you want to make sure that their headache is related to their cyst. So I insist that they see a neurologist or a headache specialist to make sure there's no other cause of their headache. That's the first thing I insist. The second thing I insist on is an MRI scan that shows the underlying aqueductal stenosis, and that's called a KISS scan, C-I-S-S, a cyst scan. And that gives you beautiful anatomical definition of the pineal region and whether they do have an underlying stenosis. And then it's all about consent. And I think it's very important to make sure these people know that this is a big operation. It can have side effects, and the results cannot be guaranteed. So I say to all my patients, look, you've got a cyst and you've got symptoms. I don't know if the two are related, but the only way of finding out is by taking the cyst out. Before you say yes to the operation, you've got to understand that I'm not going to give you any guarantees, firstly. And secondly, it's a big operation. You know, you can die from this surgery, or you can get memory disturbance or visual disturbance. And, you know, you make sure that you're very honest with the patients, because, you know, this is a new paradigm. Like you said, Mr. President, this is a new paradigm. You know, if you're operating on a patient when all the textbooks say that you shouldn't. So, you know, you're really opening up Pandora's box, and you're opening up yourself to litigation and risk, et cetera, but that's why I spent so much time telling you that these patients actually get better. It's not a placebo effect. If it was a placebo effect, we'd have a 50% recurrence of symptoms rate. We don't. These patients get better, they stay better, their MRI improves, and they're incredibly thankful. So, you know, I think we are denying a very significant percentage of patients with pineal cyst improvement in quality of life by rejecting them from surgery. So please keep an open mind to these patients.
Okay, thank you. Very brief explanation from Professor Theo. So this is another question. I would like to ask about the mean time between the first headache complaints and surgery, because in our country, sometimes the patient came late and the hydrocephalus already formed. What do you think, Professor Theo?
Yeah, well, that's easy then. If they already have hydrocephalus, then of course the decision to operate is clear. They should have surgery. These patients I'm talking about are the patients who have long symptoms. In other words, there's a long time between onset of symptoms and presentation to me. And oftentimes it's like 5-10 years. They don't have hydrocephalus, but they have worsening of their symptoms, and they seem to exaggerate their symptoms because no one's listening to them. So they come in with a long list, they come up with all different types of symptoms, and you think, oh my God, they're crazy, and you push them away because they're crazy. But these are the patients who can still do well. I promise you, even if there was no relationship between the length of symptoms and the results. So even if they come in with years of symptoms, there's still a chance that they'll do well from surgery.
Okay, thank you, Professor Theo. And is there any question? And I have one question to you. First is, do you have experience with recurrence cyst after surgery, and how you deal with the technique to prevent this recurrence? Please, thank you.
Yes. So when I first started operating on pineal cysts, I did them endoscopically through a frontal burr hole, transventricular, transforamen of Monro, trans-third ventricle, and then I just fenestrate the cyst. I put a hole in the cyst and drained them. I only did it twice, and both those patients had recurrent cysts. So then I realized that you can't do them endoscopically. You've got to do them open, and you've got to take out the entire cyst. Since I've been taking out the entire cyst and part of the pineal gland with the cyst, there's been no recurrence, zero recurrence.
Okay. Thank you. This is one question from Dr. Golden, is a neurosurgeon from Bali. I did the surgery of pineal cyst through supracerebral infratemporal approach with sitting position. What is your opinion regarding the surgical approach with the position too, I think? Yes.
I feel pretty strongly about this. Look, I was taught by Yazhigul, and as you know, Yazhigul popularized the sitting position. And look, the sitting position was excellent in the olden days when we didn't have anesthetic agents that would reduce the intracranial pressure. Those were the days when we had halothane gases or volatile gases. The brain was often swollen, conditions were poor, and you needed to do everything you could to try and reduce the pressure inside the head with the positioning. We don't have those problems today. We have anesthetic agents that shrink the brain. we have diuretic agents, we have good anesthesiology, we have hyperventilation, patient positioning, we have microsurgery, endoscopic surgery. We have now a situation where we normally have very good conditions when we open the brain. The sitting position increases the risk of surgery. It increases the fatigue for the surgeon. It's cumbersome, it's time consuming. And I don't think there's any indications now for the sitting position. I think the sitting position was very appropriate in the olden days when we didn't have good anesthetic conditions, but now we have good conditions, it's inappropriate.
Okay, thank you, Professor Theo. I think because of time, one last question. I think from me, do you have experience doing this kind of surgery in pediatric patient or in baby? Do you have some other opinion on other technique? Please.
Not in babies. The youngest patient was 7 years of age, but I've done several patients in pediatric patients, less than 18 years of age. And of course, they have to be old enough to complain of the symptoms. And they've all done very, very well. Very well.
Okay. Thank you. Because time and I think already answered all the questions. Thank you again, Professor Theo. You have a great contribution to our society, to this Congress, and hopefully you can attend another meeting in Indonesia, I think with, offline meeting. Thank you very much. Thank you.
It's a pleasure.
Yeah,
Thank you.
Thank you. Thank you. So we already have Professor Theo presentation, and the second speaker will be Professor Masataka Takeuchi. He is from Seisui Hospital, Japan. He is a specialist in vascular and also endovascular therapy. And I think he will present with a pre-recorded movie because he not present live today. Please, committee, you can turn it on the pre-recorded movie of Professor Takeuchi.
The number of the brain aneurysm treatment is increasing due to the development of devices. However, it is not suitable of the aneurysm, complicated but intracranial hemorrhage or intraventricular hemorrhage. The reason for this is that perioperative antithrombotic therapy is required. In this present, we will discuss the treatment of the ruptured cerebral aneurysm associated with intracranial cerebral intraventricular hemorrhage using a combination of the coil embolization and craniotomy. I am Masataka Takeuchi. I will discuss the natural history. The frequency of hematoma forming subcranial hemorrhage associated with the intracranial hemorrhage with ruptured cerebral aneurysm is over 34%. The most common site of aneurysm in the hematoma forming type are middle cerebral artery aneurysm and anterior communicating artery aneurysms. Compared to the non-hematoma type, the proportion of severe cases is higher. This is the first report on coil embolization and hematoma removal for ruptured cerebral aneurysm associated with the intracerebral hemorrhage. They state the advantage as follows: prevent rebleeding by treating the source of the bleeding first. Prevention of the intraoperative rupture during the hematoma removal. Minimally invasive due to minimally surgical manipulation. And characteristics. Muscle effect due to the hematoma induced brain parenchymal damage and perioperative edema. High rate of rebleeding. High rate of cerebral vasospasm. This case is 52 years old man, SH with ICH due to right MC ruptured aneurysm. Here are the complications of the intracranial hemorrhage from the right temporal lobe to the middle side. He also had a subarachnoid hematoma and underwent emerging craniotomy. Intraoperative video will be presented. The temporal clip has bounded back under pressure. You can see that ruptured bond is very large. There are reports that craniotomy is difficult in such cases. Intracranial manipulation in the state of increased intracranial pressure is highly difficult. Intraoperative ruptures without squaring the proximal artery. I would like to report a case in our hospital. 56 years old male, SH with ICH due to ruptured right IC aneurysm. Head MRI showed subarachnoid hemorrhage, right temporal lobe intracerebral hemorrhage, and subdural hematoma. The basal system was preserved, and we judged that there was time to spare. Preoperative cerebral angiography showed a right internal carotid artery aneurysm. The working angle was easy, and the aneurysm was embolized using a simple technique. After embolization craniotomy, hematoma removal was performed. The brain edema was not strong, and cranioplasty was also done. A cranial X-ray is shown. Only temporal lobe craniotomy is required, and the craniotomy area is small. Post-operativity, there was no complication of the normal pressure hydrocephalus, and the modular ranking scale was 1 at 19 days. Case 2, SH with ICH. This case is 50 years old female, sudden onset of headache. Subarachnoid hemorrhage was diagnosed at another hospital, and she was brought to our hospital. On the way to the hospital for transfer, the level went down. Head CD showed an increase in hematoma. Cerebral angiography showed an anterior cerebral artery aneurysm, which was immediately embolized by simple technique. At this time, there was no anisocoria. After embolization, immediate craniotomy was performed to remove the hematoma. The skin incisions were made around the bilateral corner suture. The extent of the craniotomy was limited to the right frontal bone. The carotid cistern was opened, and the subarachnoid hemorrhage was washed out. The post-operative X-ray is shown. The head MRI showed post-operative changes, but the modified ranking scale at 19 days was 2. Unusual cases will be presented. 44-year-old female, sudden onset of a headache. Her level of consciousness was 40 points GCS. Head MRI showed bilateral subural hematoma. There was no subarachnoid hemorrhage. Head MRI showed a right internal carotid artery aneurysm. This 3D angiogram showed bleb at the tip. Coil embolization was performed with the balloon assist technique. After embolization, one valve hole irrigation of the right side was performed and the hematoma disappeared. We have a case of the subarachnoid hemorrhage complicated by intracerebral hematoma. This case is 68 years old female, SH due to ruptured right ICPC aneurysm. Head CT showed diffuse subarachnoid hemorrhage and a thick hematoma in the left cerebral fissure. A left internal carotid artery aneurysm was found and coil embolization was performed. Post-operativity, heparin was spontaneously reversed, and no antiplatelet medication was used. In addition, a right ventricular drainage tube was inserted. 26 hours after the surgery, the patient level of consciousness decreases. The head CT showed that the subarachnoid hemorrhage was washed out, but the hematoma was enlarged. Additional craniotomy was performed to remove the hematoma. The procedure was completed with the external decompressions. The hematoma of the cerebral fissure is said to be caused by damage to the pier and the disruption of the blood vessel under the pier. The presence of the hematoma in the cerebral fissure is said that is associated with a higher rate of the vasospasm. Removal of the hematoma such as possibly is said to be a factor in the outcome. This is the final cases. This is a case of subgland hemorrhage intraventricular perforated due to the ruptured right internal carotid artery aneurysm. After insertion of a bilateral ventricular drainage, the aneurysm was embolized using a simple technique. Postoperative head CT showed a packed IVH. Packed IVH has a very poor outcome, especially hematoma of the fourth ventricle, which compression the brainstem and does not allow for improvement in consciousness. A hospital craniotomy was performed the removal hematoma from the fourth ventricle. In addition, saline was injected in the ventricular tube, washed out into several spaces. The hematoma in the fourth ventricle has completely disappeared. After 19 days, the patient's outcome was recovered to modified ranking scale 2. In summary, the following item should be noted. Thank you for your attention, Principal.
Okay. Thank you very much, Professor Takuchi. Even he's not present live today, but if there is any question, please you can write down your question and we will email to him. And the third speaker will be Professor Eka. Professor Eka already here? He's not here yet. Okay. Committee, so I will skip Professor Eka for
Professor is coming back.
Prof. Eka,
okay.
already.
Okay. Professor Eka,
Already.
good morning. Good morning, Professor Eka.
Hello.
Yes. Okay. How are you today?
Very good. Thank you very much.
We made a phone call 3 days ago.
Thank you very much. Thank you very much, friends.
Yes. I think we will not introduce him anymore because we already named he is an expert leading in vascular surgery. And this time he will talk about how to manage giant aneurysm, a challenging issue in neurosurgery. Please, Prof. Eka, time is yours.
Thank you very much. Thank you very much,
Yeah.
all of young generation in Indonesia and international member. Let me share with you about the experiences of managing giant aneurysm. So thank you very much. This is maybe that you never come to Indonesia. We have two giants in Indonesia. One is giant temple of Borobudur and one is giant Komodo lizard. So it's similar with how difficult to manage about giant aneurysm. So this is UPH Hospital Siloam. We are growing here already more than 25 years. This is our experiences in managing giant aneurysm. Total is 93 cases so far. And giant aneurysm, we know that definition as a larger aneurysm than 25 millimeter. And that's about 5% of intracranial aneurysm. So saccular aneurysm, if not rupture in the beginning, it may grow very big and become a giant aneurysm. So giant aneurysm, basically there is two original growth. Number one is from saccular aneurysm and number two is from fusiform aneurysm. So this is two different pathophysiology that we need to know before, because management is different, the danger is different, and the character is different. So it's very important to know whether they come from saccular or from fusiform. Then we need to know also the pathognomonic finding of the giant aneurysm. Number one is broadening parent artery. So normally parent artery becoming unusual with normal arteries we have learned, and then displaying a branch vessel in the neck. And then sometimes, and many times, happen sclerotic or thrombus or calcification in the aneurysm. So that's also need to be known before. Then strategy is different. Then the annual history. So annual risk of rupture aneurysm is about 8%. And this is posterior circulation, this is cavernous sinus. And the risk of recurrent hemorrhage after SAH is very similar with the smaller aneurysm. Then decision to treat giant aneurysm. Not every abnormality in the imaging, so we need to learn, yeah, I will show you later. So not every abnormality need to be treatment. Then when we treat giant aneurysm, it depends on the age, the location and the type, the mass effect and the clinical presentation, and one symptomatic that require the treatment, and also future stenosis of the artery. So we are neurosurgeons, so we have to be the best consultant for our patient, especially in the giant aneurysm. Do the best for the patient. Does not need always invasive treatment. I will show you some cases later. So need treatment if there is a hemorrhage, definitely. Yeah. Then progressive headache, worsening of the cranial nerve, and then enlargement of the aneurysm, and sometimes intractable seizure. That's all need treatment. Then I try to draw an algorithm of giant aneurysm. So the patient will come to us, giant aneurysm, sometimes with the impending rupture, impending bleeding. So from the size, from the history, we know that it's gonna be another bleeding. Then how to do it, how to manage it. Then there is two options. The embolization means that like block the growth of the aneurysm, or surgery. And surgery, then there is several ways to go. May clapping, may trapping, and clapping may with bypass, may without bypass, may high flow bypass, may low flow bypass, and trapping may be proximal, may be proximal and distal. And then we need to test with the balloon test or with the ligation test. And endovascular surgery, there is a portion for endovascular surgery in giant aneurysm. It may coiling, so coiling the aneurysm. It may stenting. It may combine. It may flow diverter. So we also know there is like a recent development of endovascular collect with the flow diverter, and may also combine of them. So basically, prevent from the next bleeding is the target of the purpose of the embolization endovascular. Then sometimes the patient come to us with mass effect. Mass effect means surgery. So don't do endovascular in the patient of giant aneurysm with mass effect. again with mass effect, it's different. Sometimes I put it here in a question mark because sometimes does not mean intervene. Again, I will show you later the case. So I like to do pre-operative planning. So if we come to the CT machine, we can make a simulation, yeah, because giant aneurysm, if you're going to do surgery, it's very important to see the parent artery, yeah, the proximal and distal artery, because managing this is not easy. So we can make a simulation whether or not the craniotomy is enough to reach the both parent artery, to see the thrombus position, and then positioning the neck artery, and sometimes artificial coil and occlusion test if necessary. So there are many roads going to the rope. So again, managing giant aneurysm, sometimes nobody single the most correct. So I just want to share with you several experiences we have. Does not mean this is the best, but anyway, the purpose to attack the giant aneurysm is reached already. So again, may clipping, may reconstructing, trapping, coiling, decompressing with or without revascularization. And if we decide to do surgery, the best approach is to maximize exposure. It's just different with not giant aneurysm, with saccular aneurysm, because we need a maximum exposure, greater exposure. So after craniotomy is sufficient, then we need to do wide splitting of sylvian vision. That's very important. So young generation, you need to have to go to the laboratorium and then try exercise to split sylvian viscera with elegantly without damaging any important vessel until we can have a wide exposure to reach the aneurysm and the parent artery. Then removal of the anterior clinoid process, very important also for the paraclinoid aneurysm, that have to be removed. Otherwise, we cannot see the proximal side of the parent artery. Then also young surgeon need to learn about orbitozygomatic osteotomy. This is very important because with doing this, then we can approach the aneurysm, not only aneurysm, but also the tumor is much lower position. So means that we will minimize the retraction of the temporal lobe and frontal lobe. And proximal approaches is very important to control if something happened. And always doing multiple clip in tandem or parallel in giant aneurysm. I will show you later that the character of the wall of the giant aneurysm is different with sacula. So if you do only single clip, mostly maybe slip in the future in the parent artery is very dangerous. Then surgical morbidity for the beginner of the microsurgery giant aneurysm is very important to know that morbidity may be caused by prolonged temporal clipping. Be careful, yeah? If you do temporal clipping in the parent artery, be careful of watch your clock because there is a limited. If we are longer of the limited time, then what's happening? Infarct everywhere. Then definitely it will increase the morbidity. Occlusion of the parent artery. Sometimes when we are not very careful, the clip going to the parent artery means occluded. And distal thromboemboli also very dangerous. And intraoperative bleeding, it might also increase the postoperative mortality and morbidity. So be careful in the section. Sometimes we got experience like a premature rupture. Then you need to be ready. What to do if happen premature rupture? Then again, we need to have a good assistant to know where the source of the bleeding and how to stop the bleeding. So let me share with you a couple of cases. This is like a conventional giant M1 aneurysm. So the patient is come from Bali. She came to me with severe headache because of the bleeding. You can see here, this is a SAH, and this is indication to attack the aneurysm. So you can see here, this might, from the CT, you might guess that it's like a M aneurysm. This is the parent artery, proximal and distal, important to see ICA. Then in giant aneurysm, again, we need to do temporary clipping in the proximal, distal, and then suck the body of the aneurysm. You know, I just use a needle wing. then I suck the conventional, then immediate collapse of the body of the aneurysm. Then there is the best time to clip. Again, multiple clip, always multiple clip. In this case, we do ring clips, yeah, to save the parent artery. So you see this, couple of clip here and save the parent artery. And then soon opening the proximal and distal of the temporary clip. Then at the time before ICG, I use a Doppler. So if you do in it's not an advanced institute, Doppler is very good and very important. See of the parent artery after clipping. That's important because again, when the clip going to the parent artery means a big problem of the infarction. So this is the post-op and the patient and then come back to Bali. So this is another case of 41-year-old male with SAH. For this admission. You can see here, this is a giant aneurysm and this is very typical. This is A1 is here, IC is here, and this is M1. In this case, you should imagine if the craniotomy better to see both and the three arteries, but sometimes you cannot. In this case, for instance, we have predicted that we may not see the A1 because it's smaller and located down and beneath of the aneurysm. And this is very tough. So in the surgery, I can clip it here, but I cannot see this. Means that I need to make a strategy. In this case again, yeah, and then what we did is we just clip here temporarily. Then I asked Dr. Hassan to assist me to suck this body aneurysm with a big syringe because there is a competition, the filling of A1 and the suction of the body. When the assistant can suck stronger than this, mean I have a couple of seconds of collapse of the aneurysm, then I clip here. This is what's happening with us. We can see here, after splitting the Sylvian fissure, then this aneurysm M1 IC, I clip temporarily, and I can't see A1. Then again, suction stronger here. Then when collapse, then I do clip here. You can imagine, yeah, sometimes this is only strategy because, well, obstructing temporarily with balloon sometimes may be done, but it's very expensive to buy the balloon. So better to have a better assistant. Then this is after clipping. Okay, this is case 3 is giant ICPC aneurysm. You see here, very big aneurysm, and this is with ophthalmoparesis when he came to me. Then what we do is we have to clip. In this case, we make a bypass first, STMCA. Then we just clip the body aneurysm. After well clipped, then the aneurysm will collapse and the ophthalmoparesis will be better in this case. Yeah? This is quite unique case. 4 years old male came to me. So he came to another doctor in Jakarta. And the doctor, he is the radiology intervention. And he did embolization of the giant aneurysm and very big aneurysm, and it was good. But the problem is, after coiling the giant aneurysm, the patient got worse of the visual acuity. Then when he came to me 3 months after embolization, you can see here, this is already defect of the campus vision. And you can see here, after checking with the DSA, there is a revealing. So anyway, in the embolization, be careful guys, because we need to check that it may always happen revealing of the aneurysm. And it's happened like this means it become worse. So this patient came to us with compression of the chiasma. And you can see here, this is with the compression problem. Well, we will not consider to another coiling in this case, but just remove the aneurysm. Because when he came to me again with a poor visual acuity, he is going to be blind totally if we don't do anything to decompress. So in this case, we open the Sylvian fissure widely. You can see here, you can have a nice anatomy of the M and the venous system. And again, it's important to drill the clinoid. So I drill intradurally here. Then you see this is the body of the aneurysm. This is the parent. In this case, I try to clip again the proximal and the distal of the aneurysm with a temporary clip. This is gold clip here. And then like case before, I try to suck the body out of the aneurysm. But you see, there is nothing happen. So the body is not collapsed. Then I directly trap here with a big clip in the neck of the aneurysm. And again, I try to suck here like a former case. Hopefully will be collapsed. But you can see here the aneurysm also is not collapsed. So I try to remove everything, open the body of the aneurysm. So open the body of the aneurysm. Then you can see here, after removal of the aneurysm, coil inside. So many coil inside. Then we need to open everything here. So open the body, then coil, so many coil just because the coiling before, right? So again, anyway, remove everything. And guys, I told you be careful. The clip, it may slip to the parent when you are not careful, right? You see here, during the surgery, slip. Then we need to replace with another clip. Then finally, total removal of the giant aneurysm. And again, because it was a very critical function of the visual because the compression of the chiasma. So the answer is remove. Then this another interesting case, 50 years old from Central Java, came to me also with very poor visual acuity. One is already totally blind and one is already very poor. So what we did here, you see here, this is the chiasm and very, very thin like a paper. So this is a comb, then I clip here. So in this case, I did not remove everything like the case before because the chiasm very much attached. So when you peel here, it may damage the aneurysm and cause totally blind. So that we didn't want. So after obstructing with a double clip here, then I just open here in the thrombus side. After removing the most of the thrombus here, means already decompressed. So decompression does not mean always removal of the body, but again, this already removed the content and the purpose is already reached that the chiasm is already decompressed. That's very important. That is post-op. So this is another giant thrombus aneurysm, 12 years girl with the SAH. This is interesting case. You see, huge. This is about 6 centimeter giant thrombus aneurysm. So what we did also, we tried to remove the aneurysm, and again with the purpose of the splitting Sylvian fissure we can find here. This is M, this is I, and be very careful, yeah. This is very interesting case. So again, the body is more than 5 centimeter. Anyway, so this is the M1 is the feeding artery. Then I try to clip here because there are so many perforating here. Then I clip not very distal because of the parent artery. Then after that, I open the body of the aneurysm like we did before. Then you need huge thrombus here. Huge thrombus, then we try to remove everything, the thrombus, as much as possible. We have limited times, then like you see here, right? So this is the, probably, this is like a draining vein coming from the body, then we coagulate, and then you can see here, we come down to the bottom of the body. The body of the aneurysm, after we remove the temporary clip, we can see there is still bleeding from the bottom. You can see this is the resource. Then in this case, what I did, I clipped the aneurysm from inside the body. After removal of the thrombus, this is the originating the feeder artery. I clip here, double clip. Why? Because this is giant aneurysm. You see that after a couple of years, definitely the aneurysm attached in the cortex. And you see this is the left side. And the girl came to me only with headache. When I remove everything, means that I may damage the cortex. I don't want to surgery. Again, need consideration. This is another lady with a giant aneurysm in the cavernous sinus. What do you want to do? She came with the ophthalmoplegia. Well, my endovascular colleagues try to do a flow diverter in this case. So flow diverter, you can see here, guys, all the coil is going down here. Anyway, so the operator cannot even insert to the distal part because of the high flow in the cavernous sinus of the giant aneurysm. You see, it's already alarm from the radiology that's over radiation. Then we decided to stop. Okay, stop, because it's already over radiation. Then you know that it's not good news because the patient becoming ischemia. So this is day one after trying flow diverter, ischemia. So become convulsion, hemiparesis. Oh my God, this is stressful for us. But unfortunately, the ischemia better in the day after. Then we try not to continue in this case because that pure from the DSA, we can see this is a pure giant aneurysm in the cavernous sinus. And I convinced the patient that it will not rupture. It may cause plagia, ophthalmoplagia, but not rupture because pure in the cavernous sinus. And this is a case with, I told you before, this is like dolichoectasis coming from fusiform becoming giant aneurysm. And this is this guy come with a tetraparesis and lower cranial nerve. 1 year in the ICU, and unfortunately he died. We have several cases, some cases very similar. This is a young man from Astana, from Kazakhstan. So Professor Yerbal discussing with me. This is similar with before, right? You see, right? But anyway, this is sometimes really with wisdom. The case I trap here, then the patient did not wake up anymore. But in the similar case in Astana, I suggested him to trap here. Then he trapped because there is no way better than trapping. He trapped here, Professor Yerbal. You see the guys coming and wake up and very good. Anyway, two similar cases, but approach costs different. Sometimes need a wisdom. So this is the case of the huge giant aneurysm without neck in the basilar artery. What do you want to do? 75 years old man with a lower cranial palsy. Anybody, any idea what you want to do with this case? Any idea, young guys, my young guys, what you want to do if the patient come to you with 75 years old man? Dr. Asra, you have idea?
I think for me, a conservative treatment, no treatment.
Well, I agree with you, Dr. Asra.
Of course.
Right? Not everything to do with it. 75. And I spoke with the daughters. Anyway, he has no insurance. You know what does it mean in Indonesia? So the case before when I trapped in 1 year in ICU, fortunately he covered from the company because a very big company. But he has no insurance. Anyway, after come back, conservative treatment, then the daughter called me, Dr. Eka, my father already went to the heaven without any suffering. Okay, I'm happy for that because it's better than dying in the ICU, right? So I agree with you, Dr. Asra. Yeah, we need to consider.
Yes,
this is the last case, guys. What you want to do? 63 years old male with a non-specific dizziness, and he is a national golfer. He is a national golfer. Remember, when he came to you, he come from Bandung. He come from Bandung. So in this case, this is the MRI. So you can see here, guys, what are you thinking about? So this is the T2 MRI. You can see here the sagittal view. Right. So the giant aneurysm already compressed the brainstem. So anybody can answer, and then I will send you like a present. So Dr. Asra, what you going to do? This is the CT angio. Do you know what does it mean? Again, this is the MRI. Sorry. So this is the MRI. You can see here. And after MRI, we do CT angio. This is CT angio. So, young guys, what you are thinking about? What case is this? What case is this? And this is the 3D CT angio. 3D CT angio. Guys, you have idea? Any idea from you? If you find this case, what you want to do? Any answer? So, you see here, this is CT angio. Where is the aneurysm? Where is the aneurysm? What case is this? Anybody want to answer, or you can with the chat with the Asra, yeah? Then again, if you can answer correct, we send you present. Anyway, so this is the case of the almost totally thrombus aneurysm, right? You will not see here if you don't see very clear. Yeah, there is some very limited. Then, and he is stational golfer. Even the brainstem compressed like that, but he golf means that the clinical condition is really very good. This case also, I do the same. That okay. Anyway, I try to observe. So you just come to me. I said maybe every 6 months, every 12 months to do another CT angio to see if there is no enlargement of the aneurysm, there is no feeling more. Probably, I also want to do any invasive for him, because if I do something wrong, then he cannot golf again, means a big problem for him, right? So thank you very much, everybody, for your attention.
Okay.
Have a nice day.
Thank you, Professor Eka, for your nice presentation and extraordinary presentation too for young neurosurgeon. So because this plenary session without question and answer session, so if you have any question, please, you can WhatsApp Professor Eka directly. I think he is most welcome to our young neurosurgeon especially. Thank you, Professor Eka.
Thank you very much, guys.
Thank you.
Thank you, Dr.
Keep
Raj.
safe and healthy.
Thank you very much.
And I think the last speaker will be my mentor from Bali, Professor Sri Maliawan. Is here now? Okay, Professor Maliawan. Okay, he's now, and he will.
Yes, I am here.
Oh yeah. As we already know that he's one of the leading experts in pediatric neurosurgery in our country. He's most dealing with some, of course, some diseases. And this time he will talk about the management of child malformation.
Let me share.
Yeah. And please, Professor Simaliawan, you can start your presentation. Please.
Thank you, Dr. Asra. I cannot share yet my slide. Please,
okay. Committee,
let me share it.
Yeah.
Committee. Good morning, Dr. Asra, Mr. Chairman. Good morning, all participants. And first of all, congratulations to Dr. Rohadi for the successful and wonderful second virtual congress of ASEAN Congress of Neurological Surgeons. And I enjoy all the presentation. But please, the committee, you cannot share it yet because you don't give me the share.
Please let Dr. Professor Maliawan as a host, as a co-host.
I'm sorry, Professor. Professor Maliawan as a co-host now.
Okay, please, Professor Maliawan, you can share now.
Yeah, thank you, Dr. Eka, for your very nice presentation. Very wonderful. How are you, Dr. Asra? It's you health?
Yes, I'm okay in Surabaya, and we still work from home. We did operation last night. I did operation for emergency case, so I cannot attend the board meeting of ACNS. Prof. Eka, you didn't join to the ACNS board meeting last night.
Please let me to be a co-host right now because I cannot share the. Maybe Dr. Eka stops sharing content and. There is no sign up.
Some difficulty, Prof. Maliawan?
There is no. Is already me to be the co-host right now?
Yes.
Yes, but there is no sign of. There's no sign of
from the
content here.
Committee, do you have a file of his presentation?
No. There's no slide for me.
Oh, okay.
No, we don't have it.
Share content kok bisa. Yesterday it's very easy, but right now,
share screen.
minutes in, we have.
Maybe you can open your presentation first, Professor Maliawan. Open your presentation first from the file. And then coming back to the.
Yeah, I share now to committee. Maybe there is no clue that I can share from my here, from my.
Yes, I think best option is you can share your presentation to the committee.
Excuse me, Professor Sri Maliawan, for the.
I cannot share it. I share new PowerPoint to Dr. Rohadi. Please check your.
Okay, maybe we will
Is
check
there?
one.
Yes.
Yeah. Yes. There's my new PPT. We are 10 minutes before the schedule.
Okay, Prof.
Bisa? Ketemu? Ada?
Yes.
Yes. Okay. There's my new slide.
Waiting for a moment, Professor. Maybe it will take 2 or 3 minutes.
Kok ada tanya share sini ya?
Okay, I think you can start your presentation.
Yeah. Thank you again for Mr. Chairman, Dr. Asra. And then thank you for all participants for your patience. And then I will start the surgery. My talk is surgery for Arnold cherry malformation associated with syringomyelia. We are 3 of us, Sri Maliawan, Dr. Vishnu, and Dr. Chakardo. Next. Yeah. We are in Bali. We are from Bali. Next. Yeah, this is Bali. Next. This is my hospital. It contains 800 beds. Next. Population number in Bali is around 4,362,000 plus minus 1 million, especially in the end of the year. There's a lot of overseas cases come. Next, neurosurgical capable hospital, 6 government hospital and 13 private hospital. There is 10 neurosurgeon right now in Bali. Next slide, please. Type of cherry malformation, there is a type 1. Next. Just a tonsillar herniation, caudal displacement of cerebral tonsil more than 5 millimeter. A very simple cherry malformation type 1. There's also, they said type O. That means syringomyelia without no cherry malformation. When you doing foramen magnum decompression, the cherry was getting better and disappear. Normal brainstem position. Next slide, please. Numerous patients have tonsil migration less than 5 millimeter, yet asymptomatic. Followed over time, they frequently asymptomatic. Cherry type 2, type 1 is tonsillar. Next slide, please. Cherry type 2 is imaging. Vermis brainstem, fourth pharyngeal herniation, myelomeningocele plus brain anomalies, hydrocephalus, caudal migration of cerebellar pelvis and brainstem, fourth ventricle, syringomyelia, small posterior fossa and larger foramen magnum, and neural tube defect occur first and all other manifestations follow. Next slide. Chiari malformation type 2, the imaging, we can see here also elongation of caudal displacement of pelvis and brainstem, meningocele or encephalocele, hydrocephalus. Next slide. Type 3, high cervical or occipital encephalocele containing cerebral and brainstem. This is one example of the MRI. Next slide. Next. Type 4, hypoplasia or aplasia of the cerebellum and tentorium, high cervical or occipital encephalocele containing cerebral brainstem. Sometimes we cannot differentiate. It's hard to differentiate between Arnold Chiari malformation and Denny Walker syndrome. Next slide. Chiari malformation overview of clinical picture. The symptom is depend on is there any compression of medulla and upper spinal cord, or is there a compression of cerebellum? Is there CSF disruption through foramen magnum? Plus, if we check it carefully, some sign of stretching of cranial nerve. Next slide. This is the symptom. If compress the brainstem, the neck pain or headache, downbeat or nystagmus downbeat, hoarse voice, palatal dysfunction, tongue atrophy, fasciculation, dysrapia, hiccup, severe snoring, respiratory dysrhythmia, facial numbness, drop attack, and dysarthria. If the spinal cord or syringomyelia develop, most of the patient scoliosis in the late phase, suspended dissociated sensory loss of pain temperature, trunk or extremity dyesthesia, wasting of the hand and arm, spasticity of the leg, sarcot joint obstruction, urinary incontinence, and arm hand weakness. The cerebellum, ataxia, and nystagmus. This if we summarize it, cerebral dysfunction 8%, brainstem dysfunction 28%, spinal cord disruption around 64%. Next slide.
Oh, masih belum bisa. Belum muncul.
Type 1 Chiari malformation. You can see here, there's a herniation of the tonsillar cerebelli more than 5 millimeter. For the other type, it's very specific surgery for that, specific management and specific modality for treatment. I focus on type 1 Chiari malformation. Next slide, please. Next slide. Tonsillar herniation more than 5 millimeter, inferior to the plane of McRae line, no associated with brainstem herniation or supratentorial anomaly. Hydrocephalus uncommon, but syringomyelia common. Next slide. Chiari malformation type 1 with syringomyelia, the clinical picture, the mildness symptom is got a mild headache when you coughing, for example. When you trigger increased intracranial pressure, you got headache. Non-radicular back pain, clumsiness, dysphagia, and dysarthria. If you get this, at least in mind, you should think about not Chiari malformation type 1. Tinnitus, fluctuating hearing loss, and vertigo. Blur vision, nystagmus, extraocular muscle palsies, and diplopia, visual field deficit. Next slide, please. Treatment options. The treatment option, if with significant symptom of blocked CSF, you can observation, wait and see if there is no significant symptom for type 1. If there is the symptom, mild symptom, for example, goal of surgery is to promote permanent flow of CSF and minimal complication. Different surgical techniques have been proposed, including bone decompression with and without arachnoid opening, tonsillectomy, other surgical procedure alternative to posterior fossa decompression are currently under debate. Some, they just open the bony structure. Bony structure, this means only leaving the dura. The dura itself, over time, it can decompress gradually the excess pressure gradually and avoid and what you see, get the free flow of CSF. A patient with significant symptom and blockade CSF flow on MRI with searing in spinal cord and symptom, posterior neck or headache when straining, swallowing or vision problem, walking problem, arm or leg weakness or numbness problem, sleep problem, and snoring and apnea. Coughing cause mild to severe headache. Next slide, please. Yeah, the goal of surgery I already mentioned before, to promote permanent free flow of CSF. That means the permanent free flow achieved when you do the appropriate decompression of foramen magnum. Appropriate decompression, they said, just open the bone, just open the, split the dura, just open the dura, and then the new one is open the dura but keep the arachnoid intact. There is many study regarding this. If you keep the arachnoid intact, that means you pretend pretend the bleeding or whatever to enter this intra-arachnoidal space, so you can avoid adhesion. And then when you, let alone when you put some graft on it. Next slide. This is the position. Yeah. In this position, you keep the chin maybe 2 fingers away from the chest, yeah? To get the secure airway, and then head up a little bit to draining the venous return pattern. Next slide, please. Yeah, we make a schematic draw for this. Remove bone and enlarge foramen magnum and restore CSF flow. Next slide, please. Next slide. Yeah, midline incision. Yeah, and then the landmark is protuberantia hospitalis externa, and to the spinous process of C2, and slowly come until we find. First time we flatten the C1, and then after that we can doing laminectomy by Ronger, and then opening the foramen magnum. Yeah? You open foramen magnum. First you use a borehole and then enlarge by Ranger or high-speed bore. very carefully in control blood bleeding at this time, because if you split the dura, for example, it's a little bit difficult. It takes a long time to control the bleeding, just to split the dura, and then be careful. Remember, you need just 3 or 5 centimeter wide when you're opening the condyle to condyle opening, and then 4 to 5 centimeter at the occipital bone. Next slide. This is what I did doing this adult Charlie-Mason type 1, and then this schematic draw here with suboccipital region, and this one we use high-speed bore to flatten the C1 and then remove the lamina of C1, and then we open the occipital bone. Okay, to carefully and control the bleeding. This be careful. To sometimes it's very difficult to identify the vertebral artery at the lateral side, and then the bleeding. Yeah, this is fibrous band, excised fibrous band. For some cases, just like this is enough in the younger patient. You open carefully the dura and then make sure the arachnoid intact. Sometimes in a small rupture, you just suture it. So you can see directly the free flow of CSF here. And then you close it by graft, so it makes sure there is no extra arachnoidal substance flow into the brain. Next slide, please. Yeah, this extra arachnoid and other cases. I just have 20. Let's see. This one. I want to pay very carefully to open the dura. Yeah? Otherwise, you torn it. Yeah? And then make sure to open slow and then protect the arachnoid. And you do. The next slide, please. This is male, 29 years old, tetraparesis at the beginning. We remove this. This is the patient before the surgery. This is CT scan. It is 6 months after the surgery. We're doing foramen magnum decompression with intact arachnoid. Next slide, please. Yeah, for this one. In this cases, severe severe compression for what cord at the level of foramen magnum. In this case, you cannot do just open the bone. You should open the dura and grab. In the mild cases, you can just open the bone, but in these cases, you open the dura and then keep the arachnoid intact. The arachnoid, it can be enlarged gradually, yeah? Gradually, but enough for this severe cases like this. Yeah? 6 months after this, narrowing searing. Yeah? But clinical symptom is still not improved. Radiologically, it's narrowing, but at least he is feeling better, but the motoric not improved. Next. This is also 42 years old. He is complained with central cord syndrome. We're doing the same way for this. And then getting better, the motoric getting better. Next slide, please. Yeah. We have extra arachnoid decompression for 18 adult patients. One patient, 12 years old. When the patient comes with symptom of scoliosis, you should examine carefully. Sometime because of tethered cord syndrome, it can cause like that. So at least in mind, you should take two things. One, is there another malformation? Two, is there any tethered cord syndrome or not? You should evaluate it carefully. Sometimes it because tethered cord, the origin of the scoliosis. So my 18 patient bone decompression and dural opening and preserving arachnoid, 15%. Neurological symptom and sign improve. Next slide, please. Monitoring. Early post-op, bed rest for 48 hours, respiratory and cardiovascular monitoring. Antibiotic continue for the first 24 hours, regular wound assessment. Late serial examination, long-term follow-up, repeat MRI. All recommend 4 to 6 weeks, but in my center, if the patient getting better, no symptom getting worse, we make MRI after 6 months. If it no changes, no progress, we recommend 4 to 6 weeks after surgery. Next slide, please. Low rate but possible complication. This is on the many reference. This is possible complication. Venous sinus injury, not in my cases. Herniation of cerebral hemisphere, spinal cord damage, cervical deficit. No, I don't have it. Respiratory arrest. No. Recurrent of searing cavity. No. Recurrent of searing cavity. Not yet. Not recurrent, but searing. No improvement. Yes. Posterior proximal hematome. No. Air embolism. No. Cerebral mutism. Not identified for my patient. Infection, CSF leak, meningitis, no. Wound dehiscence, no. Next slide, please. Post-operative magnet MRI after surgery, so a decrease in size of searing or disappearance of searing. But a significant, it's from the reference, say that, but a significant number of patients continue to deteriorate clinically, possibly due to progressive gliosis around the syringomelia cavity wall. This is, you should remind this. Next slide. The conclusion, the key point to promote permanent free flow of CSF. Removing bone area, avoid further compression, be careful, and controlling the blood is very important. Opening dura mater and keep arachnoid intact. I did, and many reference said that is less complication, addition, and sometimes meningeal sign, and so on. Minimal meningeal sign after the surgery if you keep arachnoid intact. Next slide. Okay. Thank you. Thank you, Mr. Chairman. That's all I can talk.
Thank you, ladies and gentlemen, all the participants, and thank you again very much for all the speakers with your extraordinary presentation, Professor Eka, Professor Maliawan, Professor Takriji, and I think Charlie Theo already left. I hope it will have some benefit to all of us here, and I think we should end this plenary session this time, and have a great day. Always keep safe and stay healthy during this pandemic situation. I think that's all, committee. Thank you very much. See you on the next session. Thank you.
Documentation?
Yes, yes. Okay, sorry. Documentation. Please
Thank you to
open
all
your
speakers.
video. We can see your face.
Thank you to all speakers for an amazing information.
Please, committee.
Wait a moment, Professor.
Thank you to all speakers for an amazing information and Dr. Asra for leading this session. Before we move on to the next agenda of this event, we are going to take a picture, and to all the participants, please turn on your camera and the committee will take a picture of us. One, two, three. Once again, 1, 2, 3. Distinguished guests, honorable speakers, delegates, ladies and gentlemen, the next agenda will start at 10:40 a.m. Middle Indonesian time, and to all the participants, please kindly be reminded to return here at that time. Thank you for your attention.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger. All these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
Inject saline into balloon. Inflate and deflate repeatedly and slowly. Be cautious during the process of inflation and deflation. If abnormal incident occurs, stop immediately and take remedial measures. Place the tube on the distal part of balloon. Inflate the balloon, then push both tube and balloon slowly into the tubular corridor. Inflating and deflating the balloon appropriately would be helpful.
when I need to escape. Far from all pressures and fear, I found this place. When the eyes are open, I always found peace here. Nature, the place where I always come back. Nature is more than my comfort zone. Nature is great and awesome for me. Nature always makes me calm. I want to know it more and more. Like nature knows what I need. And Lombok teach me what is concern of nature. Do not care about background, colors, and differences. Lombok united for a better future. Now I know. I, you, and nature will never be separated. When world is changing, we should change immediately. And Lombok is more than a beautiful place. Lombok is a harmony. The harmony of nature and human that always makes me fall in love.
Distinguished guests, speakers, delegates, ladies and gentlemen, now we move on to the fourth plenary lecture with Dr. Muhammad Tohar Arifin as a moderator. Before I hand over the session to Dr. Muhammad Tohar Arifin, please allow me to read his CV. Dr. Muhammad Tohar Arifin was completed his medical studies at Diponegoro University in 1998. He continued his master's studies in biomedical sciences at Hiroshima University and graduated in 2007. In 2010, he was completed his master's studies at Erlangga University and graduated as neurosurgery specialist. And now, I hand over the session to Dr. Muhammad Tohar Arifin. Time is yours.
Okay, good morning, good afternoon, and good night for all of you. Hello, Gail. How are you? You can hear me? Okay, thank you. We will have the decision, and we'll have a lecture about education and residency in neurosurgery. For the first, we will have Dr. Gail Russo from State. She is neurosurgeon in Graduate School of Medicine of Elmhurst, Illinois, She has received her medical degree from George Washington University School of Medicine and has been practiced for more than 20 years. She will talk about okay.
I can help with that. I'm going to speak about diversity in neurosurgery.
Okay, diversity in neurosurgery. Okay, thank you.
My pleasure.
Okay, and time is yours for 30 minutes, and then after that we will have discussion.
Very good. Thank you very much. Thank you so much for your kind introduction. Can you see my slides?
Okay, good. Yeah.
You can see the slides fine?
Yeah.
Great. Well, very nice to see all of you, and it's an honor and a pleasure to be here with you. There is literally nothing I wouldn't do for my good friend, your president, Yoko Kato. And I also have had the great pleasure of being hosted by my friends in Indonesia, in your country, many times. So I wish we were all physically together there in Lombok today, but I hope that we will be very soon. My talk today that Yoko asked me to speak on is a non-technical talk. As was mentioned, I'm a skull-based surgeon. I trained with Ed Laws in Washington, D.C., and then with Peter Janetta and Lalagam Shaker. My practice has been primarily skull-based surgery. But today I'm going to talk with you about something that is different, but affects all of us, and that is diversity in neurosurgery and what it could or should do for our profession to diversify our ranks. And the work that I'm presenting today has been published in World Neurosurgery in an upcoming book. I'm very pleased to have worked with this diverse team of Kim Klein, Lartigue, and Harvey Jumper. So let me jump right in. This is the paper that we published last year about this.
I'm sorry, Professor.
Yes?
Excuse me. Your slide is not coming yet.
You don't see the slide.
Yes, we don't see the slide.
I'm
Please
sorry. So let's
can you
try
share
again.
Screen? Okay.
I am sharing screen. Can you see now? Let me try again.
Not yet.
Can you see the slides now?
Not yet, Professor.
Okay, I'm going to come out. You saw them before, right? I asked you about that.
Yeah,
You
But
saw them
no.
and then they were lost?
Yeah, but we cannot see now.
Can you see now?
We cannot.
That is very interesting. Okay, you know, we've all been working on Zoom for so long that I thought I had seen every problem you can have. From my side, I see them. I'm on the desktop. Let's see, what is a better way to see if I can find them? I'm going to, let me try a couple other things here.
Professor, if you need assist, please kindly share your slide in the chat. In the chat, maybe we can assist you from here.
Share them in the chat.
Yes,
would you
in
like
the chat room.
Okay. Would you like me to email them to you? Is that what you're saying?
Okay, it's okay.
Or you can restart your screen share again.
Yeah, let's try that again. I apologize, and I've never run into this problem before.
It's okay, Professor.
Can you see it now?
Not yet.
Well, why don't we do this? How about if I quickly email the slides to you and you run them. Does that make sense?
Yeah.
It is.
I'm very sorry. I had asked about whether you wanted to practice beforehand. I really don't know what the problem is here. I'm sorry to inconvenience anyone, but what I'm going to do here is send you my slides. And it's coming to you now. I apologize to all of you. I'm not sure why you're not seeing them, but we're getting them to you now. And I certainly can go through and talk about it without the slides, but I would like to be able to share them with you because the slides themselves show some elements of diversity. You should have received them by now. I'm getting a sent message. Did you receive those?
Not yet, Professor. We are waiting in the email.
And it says it was sent.
Okay. Yes.
You got them?
Yeah.
Great.
Yeah, we get it.
Interesting. So why don't we just open them up, and I promise to catch up and not delay your talk, the next talk. But I would be very grateful if you would advance them. I'm not sure why the link isn't working. So just tell me when you're ready and we'll move through that way. Thank you very much.
Yeah. Maybe we will start in 2 minutes.
Please share.
So while he's doing this, the concept that I want to speak with you about is the concept of how our profession can best move forward and what is the evidence that having a global and diverse workforce will advance the profession that we all love. You know, in the last year, we've had many demonstrations around the world that were related to gender and racial inequities. So we thought that it was important to address these issues in neurosurgery as well. So we have studied very carefully business, military, multiple other systems to see what neurosurgery can learn from them. And here we go. So I'd like to share with you what we have learned about diversity in neurosurgery. Next slide, please. I'm going to ask you to advance for me. So we published this in World Neurosurgery last year. There are other papers coming out on the topic, and a book chapter is in press. Next slide. So I think we all agree that we need the best possible people in neurosurgery. And the point of this talk is to give you the evidence that a key driver of excellence and innovation, which we need in neurosurgery, is diversification. Next slide, please. So these are the 4 areas that I'm going to discuss with you: academics, our issues specific to neurosurgery, what we can learn from other professions, and the benefits of diversity in other systems. Next slide, please. And maybe what I'll do is I'll put my thumb up like that when we're going to next slide. So the National Institute of Health is the group that funds neurosurgical and all medical research in the United States, and they take diversity very seriously. Next slide. So these are just some screenshots from the NIH website, but it shows that there is actually a science to studying diversity, to how does one mitigate obstacles to success as an individual or as a profession. what are the ways that we can be sure that we are recruiting the very best people to go into neurosurgery. Next slide, please. So I'd like to give you a little background of diversity issues within neurosurgery. Next slide, please. So one might say that neurosurgery was gender-wise diverse from the beginning. This is the first photograph of what is now the AANS, and you can see that there was a woman. So from the very beginning, it was not an all-male field. Dr. Louise Eisenhardt is very well known to American neurosurgeons. Although she was not a neurosurgeon herself, she was the first neuropathologist. She was Harvey Cushing's right-hand person, and as you know, they published very important initial monographs together. She was the first woman to be president of the AANS, and she was the first editor-in-chief of the Journal of Neurosurgery. So she led that publication to the high place it is today. Next slide. And we'll quickly go through then the inspirations around the world. So in the 1940s and 50s, Diana Beck in the United Kingdom, Sofia Ionescu in Romania, were general surgeons who started to focus their practice on neurosurgery, just as Harvey Cushing had done. But it was actually Turkey that produced the world's first board-certified woman neurosurgeon, and that was Professor Altanok in 1959. And then I'm proud to say that Dr. Ruth Kerr Jacoby at my own institution of GW became the first American woman to be board certified, and that was in 1961. Next slide, please. You all probably are very familiar with a small but very mighty neurosurgeon from India, T.S. Kanaka, whom we all loved and who left us not so long ago. But she, of course, was the first woman professor to be board certified in neurosurgery in Asia in 1968. Alexa Kennedy was the first African-American woman. And you can see there's gender disparity, racial disparity here, because the first African-American woman in the US did not get board certified until 23 years after the first white woman. And then you all probably know Naja El-Abadi, who is practicing now and is the first woman professor of neurosurgery in Africa. Next slide. This early picture from 1989 is the original group that formed Women in Neurosurgery. These were all the women who were present at a major meeting that year. Next slide, please. Times have changed, haven't they? And that was in 1989. By 2008, Women in Neurosurgery was well known enough that the AANS Board of Directors asked us to write a white paper on the recruitment and retention of women in neurosurgery. New slide, please. And in that same issue of Journal of Neurosurgery, next slide. Just advance and advance again. In that same issue, there's another photograph here, please advance, is Jim Bean, who was the then president of the AANS, who wrote an editorial about the future and retention of women in neurosurgery, saying that it was time to dismantle the barriers and offer a hand across the remaining gulf that separated the privileged from the deserving. So that's an early view of looking at diversity from the point of view of fairness or justice. Next slide, please. And advance again. So and looking at fairness, we can look at a number of factors. Here we're looking at the very slow growth from 1980 to 2020. And you can see, although the number of women in neurosurgery has increased, it's increased very slowly, as you can see in this article by Abash and Rutka in 2018. Only 6% of certified neurosurgeons in the US are women, only 4% are Black or African American, and it's extra difficult if you're both Black and a woman in the United States. Next slide, please. So there's also an academic progression gap. This is very well known. If you look at this publication from Curious, you can see women start at the assistant professor rank, but they don't move or advance the way men do, even in neurosurgery. Next slide, please. Thank you. And you can see the fall off there in those curves. Next slide, please. There's also a pay gap, which you may not care about unless you're married to a neurosurgeon, and then you care a lot when you look at paychecks, and you want to be sure that people are getting equal pay for equal work. So all of these arguments are now within the realm of justice and fairness. Next slide, please. This is just a reminder that progress is being made both by the World Federation, by the European Association. The Asian group has been phenomenal in this, and that has been largely powered by the engine that is Yoko Kato. Next slide, please. So that brings us to this historic vignette. You may be familiar with the fact that neurosurgery as a profession is thought to have started in 1919. So in 2019, we started a series of papers that were looking back at the first 100 years of neurosurgery and then forward to see what we could predict or plan for the future. And one of those papers was this one about the contributions of American women in the first 100 years. Next slide, please. And that paper started writing groups from all over the world. So there were writing groups that were documenting, researching, and publishing the progress in neurosurgery of women neurosurgeons in Australasia, in the Middle East, Central and South America, Europe, and Africa. And many noted this early 2011 paper of Robert Spetzler's, one of the few single author papers in which Dr. Spetzler wrote that the scant historical literature devoted to women in the field of neurosurgery suggests not that their contributions are less worthy than those of their male counterparts, such as their contributions have yet to be fully recounted. So I'm happy to be able to tell you that this year there's been nearly a dozen papers published, and the history of women in neurosurgery has now been published. Next slide, please. Many of those papers appeared in Journal of Clinical Neuroscience. So then let's move from gender to racial diversity. You can see the first African-American man to be board certified in neurosurgery was Clarence Green in 1963, followed in 84 by Dr. Kennedy, 85 by Dr. Hyde. Next slide, please. This is an outstanding and inspirational mentor to many, Latunde Odeku, who was a Nigerian neurosurgeon who trained in the United States and then went back to Africa and worked in Africa. He's an outstanding poet as well as a great neurosurgeon and is inspirational to many of us. Next slide. And many of our African-American Black neurosurgeon colleagues, next slide. If you advance, you'll see that they actually made a statement. Next slide, please. About the issues regarding race that were part of the Black Lives Matter movement. And our colleagues who are Black neurosurgeons wrote last year that excessive use of police force and violence is a public health issue. So we're starting to move from the justice issue to advocacy issues within our diverse neurosurgery cohort. Next slide, please. There are Asian Americans who are outstanding in America, and Linda Liao is just one of them. Next slide, please. Also a member of the National Academy of Science. And then as we talk so much about immigration in the world these days, it's important to reflect upon how much neurosurgery has benefited from geographic transplants. People like Dr. Yasserko, Dr. Q, Dr. Sontag, who left the place where they were born and made tremendous contributions. So we need not fear emigration. Next slide, please. We need to talk more about neurosurgeons with disabilities. Corinne Marasco, my good friend, is the chairman at the University of Michigan and the first woman chairman of a department of neurosurgery. She operates from a wheelchair. You all may know Dr. Michael Biggs in Australia, who actually was told by a senior that someone who had a stutter could not become a successful neurosurgeon. And now, of course, we have a president of the United States who has had a stutter. So we know that we can benefit from this kind of diversity. We have, and we need to continue it. Next slide, please. And as we get older, think about ageism as well. There are so many opportunities for people to be giving back. We're all living longer. Hopefully we have both health and resources that will allow us to be able to give back long after, in some cases, 2 decades or more, after we stop the daily practice of surgical care of patients. And so we need to think about how we harness this valuable resource of more senior neurosurgeons. Next slide, please. There are great examples of this. Bill Gates, for instance, who created Microsoft and then at age 53 stepped away and is doing what he considers the most important work of his life now with his foundation. So we wrote about this in an op-ed in JNS. Next slide, please. So let's look at what we can learn from other professions and take a quick look at those. Next slide. So one of the first in the US, we can advance through these, is lessons from the military. And what we know is for there to be a positive step in integrating any workforce, it needs a high-level political commitment, such as the integration of the military in the US after World War II. Next slide, please. So this is a quotation from Franklin Delano Roosevelt. It sounds so much like today. It seems he could have said it just today. We are faced with the preeminent fact that if civilization is to survive, we must cultivate the science of human relationships and the ability of people of all kinds to live together and work together in the same world and at peace. And this is really important. Next slide, please. So it came to not him, but to his successor, to President Truman, to integrate the US military. And in my country, that's the best example of a successful program of making opportunities available to people regardless of race. That's the US military. Next slide, please. You can see that there's a busy slide, but it does show that every branch of our military has been well represented now. So we have great diversity within every branch of our government. Next slide, please. But just like with neurosurgery, the minorities have not yet risen to the top. But luckily for the military, we have congressional oversight that will make sure that that progress, so that allows people of racial and gender diversity to rise to the very top ranks of the military, will occur. Next slide, please. So what have that's what we've learned from business, where there were congressional or legal mandates that made it important to bring that justice and fair equity of access to bear. But what about business? In business, we've learned that diversity improves performance, it increases competitiveness, it improves relationships. In business, there's not so much a driving force to be fair, but to be profitable, right? So let's see what business does about diversity. Next slide, please. So these are slides from Boston Consulting Group, but you could look at Harvard Business School, Bain, McKinsey, Booz Allen Hamilton. They all show the same thing, that companies that have above average diversity scores in their teams actually make more money. And who doesn't want that, right? Next slide, please. This is so widespread in its acceptance that there are actually those who believe that diversity targets should be part of the compensation of CEOs of companies, that if you disclose them, this would give top executives a financial incentive to diversify the workforce, or give a public scorecard so that the public could make investments based on that, because people want to make money. Next slide, please. We had some great lessons from politics during the pandemic with women CEOs and how they handled the coronavirus, several of whom you'll recognize who are from Asia. Next slide, please. So then finally, let's talk about the benefits of diversity of other systems, economics and ecological perspectives before we close. Next slide, please. So it may seem obvious to you, but we're moving now to talking about benefits, how one makes a profit. So we've moved from justice to profitability. And it may be a surprise to realize that the 1990 Nobel Prize in Economics actually went to Harry Markowitz, and it was for his economic theory of diversification, in which Dr. Markowitz and his team had proven that the more types of investments a person makes, the more likely they are to have a net gain and lower risk. Next slide. This does have implications for neurosurgery. Now, if you look at that top list, these are all the economists whose primary practice has been to diversify portfolios. Warren Buffett is the classic example. They're not a very diverse looking group, I know, but those on the bottom are the up and comers, and you may recognize some of those. That's a more diverse group. They are also experts in portfolio diversification, and they're rising to the top ranks because that's where the money is. Next slide, please. We want profitability in business. We want innovation and excellence in neurosurgery. Next slide, please. So one could ask oneself regarding biodiversity, is it merely chance that there are so many, over 5 million species on the planet? Or is it possible that there's some Darwinian advantage that's been conferred on the planet by having this diversity that increases net gain and decreases risk? Next slide, please. And the papers within the biological and ecological sciences are really too numerous to mention here, but it is absolutely clear that that biodiversity improves the average level of performance of any biologic system. It enhances its productivity, it enhances its stability, and it improves its resilience to change and lowers the risk of negative outcomes. Next slide, please. So if we put together the evidence here, even if we move beyond justice and fairness, but we all agree that we need the best possible people in neurosurgery, the lessons of ecology, the lessons of economics, the lived experience of neurosurgeons over the years, of our military that had a forced integration, is that excellence and innovation and strength are greatest with diversification. And that's what we want for neurosurgery. We want a strong, innovative, excellent profession. Next slide, please. So I'd like to thank the very diverse team that has done and continues to do this research with me, including importantly from Asia, Eliana Kim. Next slide, please. I'd like to thank my colleague at UCSF, Sean Hervey-Jumper, who participated in this work as well. Next slide, please. And then there's two other things about diversity, just the graphics that I'd like to share with you, which is the reason to share the slides. This is a South American student from Peru who came to the United States to get his master's degree in graphic design. And this is the unity and diversity flag that he designed. And we use it with his permission. Next slide, please. And then finally, I'd like to tell you about Jeff Hansen, a young patient with neurofibromatosis who was visually challenged because of bilateral optic nerve gliomas. He saw that as a benefit and became an artist and philanthropist and raised over $6 million for philanthropy. So there's many ways of looking at diversity, but Jeff, as a patient, has contributed so much despite what some would consider a handicap. Next slide, please. So with that, I want to leave you with my contact information. It is important for us who love neurosurgery to be sure that we attract the best and the brightest to our field, and that we create a ambience within our field so that all are welcome, so that that kind of diversity can drive excellence and innovation. So with that, I'll close. I'll thank you for the opportunity to be with you. Thank you. We're done. Thank you.
Thank you, Dr. Gail, and for your nice presentation. And we still have more 5 minutes. So I discuss with the expert here, and any comment or any please to the conference committee, please unmute the participant if they want to ask directly to the speaker.
You know, we all who have trained in neurosurgery know that we as neurosurgeons have a reputation for being a tough group, right? And we're not always a welcoming group. And I will say we're kind of proud of that. We're proud of the fact that we are able to do difficult things, and we have what we call thick skin and broad shoulders. And that's good. We need to have that. But we, at the same time that we develop our technical expertise and our ability to withstand the stress of our training and our practice, we want to practice in such a way that we are attracting the best young minds to neurosurgery. We want to be sure that the next great technical surgeon, the next great thinker who's going to find a better way to treat our patients is not turned off, but actually is attracted to what we do. And part of that is diversification, is making sure that anyone who might be interested in neurosurgery sees someone who looks like them and acts like them, or at least feels welcome. We haven't done such a good job of that in the past. And we hurt ourselves because there are people who don't choose our profession who could have added a lot.
So it means that everybody should have the opportunity to become a good neurosurgeon. Is it all right?
Every bright, hardworking student should have that opportunity. We're not talking here about lowering standards at all. We know the standards need to stay very high, but the outcomes of patients are not only determined by how good our surgery is, it also is, does the patient trust us to come to us? Does the patient or their family go home and do what they need to do to stay well and get better? And having the ability to communicate properly, maybe even with someone who looks like you, acts like you, who has your own background, is important to healthcare for people.
Okay, thank you, Doctor. Time is up and it's nice presentation, and we would like to move for the next speaker. This is 1 minute. Next speaker is Dr. Professor Hiroyuki Toyama from Japan. He is Chief of Neurosurgery in Shimada Memorial Hospital and Neurosurgery Clinic Shizuoka in Japan. He was graduated from Tokai University in Kanagawa Prefecture, and he was joined to Tokai University Hospital in Kanagawa, and he was graduated from in April 1998 to 2000. He was director of the neurosurgery Ikegami General Hospital in Tokyo, Japan, and now he is practiced in Shida Memorial Neurosurgery Clinic. Professor Hiroyuki Toyama times 30 minutes for the presentation. So this is live or video presentation?
We will use record video.
Okay. So please start.
Thank you very much for giving this opportunity to talk about my study. I'm from the city Shizuoka, Japan. Our hospital, Shida Memorial Neurosurgical Clinic, started in 2005, 16 years ago. And our hospital is kind of micro hospital because we only have 19 beds and some operation rooms. So in this time, Professor Yoko Kato asked me to present our educational system. I'll explain about my clinical results and my opinion for the neurolismal treatment during 16 years. After that, I will present the surgical training method using 3D printed model. This is our result of our neurolismal treatment during 60 years. Because our hospital doesn't have an emergency room, almost all of our cases are unruptured cases. Out of 614 cases, there is only one case of permanent deficit. It was purpose injury. But this patient can walk by themselves with a cane. We decided the treatment method depending on the case. We can either use neck clipping or a vascular treatment method. In unruptured cases, I performed a neck clipping 72% of the time and 28% in vascular. Recurrence rate, there are two recurrence cases in clipping case. They're both ruptured cases. On the other hand, out of 170 cases, there was a total of 12 recurrence cases in the vascular treatment. It was about 7%. The ACNS study reported the recurrence rate was over 15%. Especially with large animals, the recurrence rate is higher than creeping. In recurrence cases, this is one of the recurrence cases with left buttock artery. First, I performed core embolization by simple technique, but after 2 years, the patient came back, so I did coiling again. However, it still had a recurrence, so I did coil again with the enterprise stent. Next, this case is less cavernous portion symptomatic aneurysm with fixed nerve palsy. I did core embolization with stent Wilhelm atlas by local anesthesia. During coiling, this patient felt bad, so I stopped the treatment, so it wasn't enough coiling yet. 3 months later, it was recanalization. In this case, I think flow diverter stent pipeline would be best, so I will use that next time. This is recurrence and after the gets on creeping. I performed the neck creeping. I use the 2 creeps and remove the temporary creep. I see what I can, and 3D CT scan was okay after the operation. But 10 days later, it relapsed, so I performed the re-operation and I found the re-breathing point. I will show you the before slide. We reviewed the creeping better and we consider what should be done. That was always keep the parallel position between cross and creep line and never slide that line. I will explain about it later using 3D printer model. Therefore, I think that we must always prepare for a severe situation. We need to train and simulate all the time. So I will present the simulation and training method using 3D printed model. Nowadays, 3D printers are perfect and have become widely available. They are also used in the medical field. In Japan, 3D printers are covered by insurance in some kind of medical field. But if you order the 3D printer model for each case, it's very expensive and it will take a long time to make them. At the hospital, we started making 3D printer models, predominantly cerebral aneurysmal models from 2013. And we use them for preoperative diagnosis, surgical simulation, and as educational tools. Also, recently we are making complex bypass models and vascular models, and we are developing the bypass training system. Furthermore, our 3D models are faster, more convenient, and more inexpensive than ordering models from startup companies. In this report, I will explain their usefulness and utilization methods. We are making aneurysmal 3D printer models for all cases on daily basis. There are 322 cases of cerebral aneurysm treated in this report during the 93-month period, and some other surgical cases. And 3D printer, diagram conversion software, and ME devices used are as shown on the slide. I will explain by the making process of the 3D printer models. First, diagram data from MRI and the 3D CT is converted to 3D sterile lithography using diagram conversion software. Then, printed in this model, it must be cut out by our hand. You can make the holistic model as you can see. To make this holistic model, they created APS-ready models is coated with silicone and dried. After that, the APS is dissolved in the acetone. Also, we can make brain parenchyma cycle model, as you can see. This software parenchyma model is really useful as an educational tool. It compares attachment to actual surgery. For example, when you want to train a brain holder. For simulation, I will present a typical case. This is a case of left internal carotid aneurysm. We can create a simulation by making an ABS model and a forensic model with scar. It's easy to make the model and simulate a simple case like this case. We can understand easily the perception of the region using the 3D printer. Therefore, while the cultural operation, we always consider thinking about grip breadth length. Using 3D printer is useful to decide when grip length or type to use before surgery. For clipping practice, on the actual surgery, we cannot do clipping again. This holistic model will allow you to clip and clip again. So it's really useful to practice clipping. As you can see on the slide, this model is similar to left-sided aneurysm I presented before. It can be review of the operation. These models are really flexible. It is upside down just before I presented aneurysm. We can try doing it over again. For review, I will introduce my current case. This is a left MCA trifurcation aneurysm with thin branch. I was planning to peel off the neurismal dome, but it was difficult to peel off this M2 branch and it took about 30 minutes to do temporary clip twice and MVP depressed. I tried to skip method with the fence flat clip, but it didn't fit. So I used 2 clips and finished this clipping. I see the was almost okay, but I thought it was not completed clipping. Then for up this was okay, but I think it was not good. So I reviewed this case using 3D printer. With 3D printer models, we can review this kind of complex cases. I made this case model and I could find a way to peel off the pulpit from a neurismal dome. And now I introduce a bypass drying method using this 3D printer model. We made high-flow bypass model. It will be useful as an education tool or for understanding concept of the operation. In this way, I think that the 3D printer model will become widely accepted using other fields. I did bypass 2M2 from external carotid artery. We are doing bypass as acute progressive cerebral infarction. Also, I always do the NASMA training before bypass surgery. In the case of SDA-MCA bypass, I think individual simulation and training are not necessary. But you can share the skills with your operating staff by this training using realistic model. And it's really useful method for learning the procedure of the operation. We made bypass model with ICD. I think these skills are useful to get good result with aneurysmal treatment. However, the vascular surgery model can be made for each case. This is the case of vascular tap aneurysm. And this variety model is very useful for pre-shaping the microcatheter. Also, the movement of the catheter during cord embolization can be observed by making the spherical model clearly. In this case, cord embolization was performed for left ICA by using the spherical model with the kind of flow applied. Placement of the microcatheter can be simulated. This kind of simulation is very useful for expecting catheter and the cord movement. We are doing bypass training with 3D printer model. I believe this training system can be developing our surgical skills. And I think surgical training is step by step. In conclusion, I think there is a strong possibility that 3D printers must be used more widely in medical field. Thank you very much for your attention.
Thank you very much for Professor Toyama. So we still have time for discussion. So I noticed that Professor Toyama is here. Good afternoon, Prof. Hiroyuki Toyama. Can you hear me?
Good afternoon. Can you hear? Good afternoon.
Yeah.
Good afternoon. Can you hear?
Yeah, Professor.
Yeah. Thank you very much for giving this opportunity to talk about my 3D printed model.
Yeah, it's helpful for the training for the neurosurgeon to be familiar with anatomy and anticipate the what happen will be in the operation. So it's important, I think.
Yeah, and I think that it's very important and to know the anatomy and the perception of the region, acute surgery. So our training method is very usefulness, I think.
And for the preparation, do you or you have your own staff to prepare for that tools, or you collaborate with another department?
Another department, yes, and it's only our hostel and collaborated the Tuka University. And the other hostel, some of the hostel, but on basic and only our hostel.
Okay.
But sometimes and we ordered the other hostel, and because it's very cheaper than the other countries and order.
Okay. If the pandemic is already finished, it's better to demonstrate your technique, demonstrate your presentation offline, so we can learn more about how to prepare your technique. Okay, thank you, Professor Toyama.
Thank you very much.
Yeah. And we move to the next speaker, Professor Tadashi Watanabe. He will speak about tips and feasibility of extended endonasal approach. Professor Watanabe is Associate Professor of Department of Neurosurgery, Aichi Medical University in Nakakute, Aichi, Japan. He was graduated from Nagoya University School of Medicine. And this is pre-recorded or live committee?
Yes, pre-recorded.
Okay. So please start the video of the Professor Tadashi Watanabe.
Hello, everybody. This is Tadashi Watanabe from Nagoya, Japan. And thank you for the opportunity to make a presentation here, Professor Rohadi. And today's my topics is tips and feasibility of endoscopic endonasal approach. Here I show you the surgical equipment and the setup of our approach. We use a 4mm rigid scope mounted on the pneumatic floor standing holder. I prefer uni-arm Mitaka, and now I use the 4K camera system, and with the navigation system, which is I prefer magnetic one, and tools are always thin and flexible. I show you later, and I use sometimes a VEP and MEP nerve monitoring for a third or sixth nerve if I need. And this is OR setup. The patient head is raised 15 to 20 degrees up, and we set 2 monitors in front of the surgeon and navigation monitors. This schema shows the position relationship between tools and endoscope. If you put the endoscope in upper area, tools are moving below the endoscope. And if you put the scope in the lower part, the tools are moving above the endoscope. It's like a samurai posture. Okay. So this schema shows the invisible wall created by the endoscope itself in the surgical field. So in this black part, you cannot touch the tissue, touch the objective, because it obstructed by endoscope. So if you want to cut the dura mater perpendicularly, you better put the endoscope in lateral position, like 9 o'clock in the schema. And if you feel the obstruction, you cannot touch the tissue, you can bend the tools a little bit, the tip of the tool. You can touch to the certain objective. This is the tools I use, the monopolar bipolar coagulator and fine forceps and the rotating dissectors and malleable disposable sucker. Sorry. Okay, let's move to the anatomy of this endonasal approach. This picture shows the right nasal cavity. This is the inferior turbinate and middle turbinate and uncinate process and septum. This schema is a caloric picture and showing lateral wall of the nasal cavity. There are 4 basal lamellars. The first one is uncinate process, and the second one is Blua ethmoidalis, and third one is grand lamella. This is the root of a middle turbinate, and the fourth one is superior turbinate. And beyond the fourth basal lamella, there is the skull base. It means optic canal and planum sphenoidale. So the anterior and posterior ethmoidal artery is a very important structure. It is running on the roof of ethmoidal sinus. So we have to watch out not to injure these arteries. And the Vidian artery and the nerve and Vidian canal is one of the most important structure in this approach. It means a lateral limit of wide sphenoidotomy. You can see the canal in the coronal section of CT, just medial to the foramen rotundum. This is the schema of arteries in the nasal cavity. Other than the anterior posterior ethmoidal artery, the most important artery is sphenopalatine artery. It's running in the pterygopalatine fossa, and it branches the posterior septal branch. And it's important when you make the septal flap. This schema is an operative view of sphenopalatine artery. Beyond the posterior wall of maxillary sinus. After drawing the maxillary sinus, you can expose the sphenopalatine artery, and it's running in front of the Vidian canal, branching the Vidian artery, and then branches the posterior septal artery. This is the anatomy of posterior wall of sphenoid sinus. It is the most important anatomy in this approach. The cell thoracica, planum sphenoidale, tuberculum celli, optic canal, and carotid prominence, and medial optical carotid recess, and lateral optical carotid recess. The lateral optic carotid recess is there is optic struck at the backside of lateral OCL, and the backside of medial OCL is middle clinoid process. And this is the superior hypophyseal artery, which is very important when you do approach to a craniopharyngioma. It branches from IC directory. Sometimes it is 1, sometimes 2. It feeding the stalk and optic chiasm. So this paper showed the unique branching of superior hypophyseal artery. It's called a candelabra-like branching. So it means after the branching from the IC, the one branch is going anterior, and the other one is going posterior. So we have to watch out the running of this SHA. Otherwise, you can injure the trunk of this artery, and it sometimes causes the deterioration of visual function. There's another small branches in this approach we have to watch out. one is inferolateral trunk. It's branching from C4, IC C4, and it is inside the cavernous sinus. So when you go into the cavernous sinus, sometimes you come across it. And meaning the hypophyseal trunk is branching from C4 junction, and when you follow the tumor embedding into the cavernous sinus, sometimes you come across this artery. And the inferior hypophyseal artery is branching from IC, or sometimes from branching from inferior hypophyseal trunk and feeding the pituitary gland through the medial wall of the cavernous sinus. So when you do a transposition of a pituitary gland, you have to cut it. You have to find it and cut it. So let's move to the approach. This is a transeptal approach, cutting the mucosa at the level of anterior edge of inferior turbinate. So, and we elevate the periosteum from the cartilage and the bony septum. After removing the bony septum, we expose the anterior wall of sphenoid sinus and drill out the sphenoid sinus as much as possible. And the lateral limits of the wide sphenoid artery is a Billion canal. And also we do a wide cellar opening. I prefer drilling in this stage. I drill the cellar just between the carotid prominence and the cellar prominence, and do a wide cellar opening as much as possible, so we don't lose any corner tumor at the corner. So dural incision, I prefer inverted T or Y incision for especially adenomas. And the point is, the tip is just cut the dura mater and plus the thin layer of pituitary gland and preserve the pseudocapsule of the tumor for adenoma. So once you find the border between the pseudocapsule and thin layer of pituitary gland, you can dissect them all around the tumor with round dissectors or blunt ring dissectors. And after the dissection, you can do the internal decompression, and after that you can follow the border. Once you remove the tumor out, the diaphragm cell line is descending down and ballooning under pressure of CSF. And we always put the abdominal fat to the cavity, and we make one suture tucking the dura mater, and then we replace the bony reconstruction, and then we cover the sphenoid mucosa on it and fix it with fibrin glue. And if there is a high flow CSF leakage, we use the mucoseptal flap. And this is the schema show the line of mucoseptal flap preserving the posterior septal artery. I show you another non-functional adenoma cases, and so now I'm doing the wide cellar opening just along the edge of the cellar. So And now I found a border between normal gland and the pseudocapsule. So we dissected all around the tumor as much as possible, and then I cut it again, cut the dura mater again. Partially the pseudocapsule is torn because it is very fragile, and after the decompression, we found the border again, and preserving the layer of a normal gland, I'm dissecting the tumor with a pseudocapsule, and this is the last part of the tumor. And carefully I'm doing the hemostasis because this patient was taking antiplatelet. And recently I used Duragen for packing. So it is very useful in this approach also. And inlay and onlay Duragen was placed using a Dura suture, and we replaced the bony cella floor and cover mucosa. This is a post-operative MRI without fat graft, and the 1 month and the 2 months post-operative nasal cavity. It is already clear at this point. Okay, let's move to the extended approach. First, I show you the anterior extension for craniopharyngioma and the meningioma. We remove the planum cell, sphenoidale, and tuberculum cell, and during the medial side of optic canal. Sometimes the bony structure is very thick, especially at the upper side of optic canal. This asterisk mark is, so we have to watch out not to injure, and also the heat injury of by drilling. And once you have got the corridor, you can see the interhemispheric area and of the chiasma, everything. And also stalk and PC and PCOM and basilar tip complex and mammillary body, you can see. Okay, this is pre and post operative CT and MRI of craniopharyngioma and meningiomas. And I show you some examples of craniopharyngioma after removing the cella and planum complex. We will replace this bony structure after the surgery. And now I'm cutting dura mater, preserving. This is the internal intercavernous sinus. I'm coagulating and cut it, and tacking up with 6-0 Prolin. And now I'm dissecting the tumor from the optic nerve carefully with a fine forceps, and you can see the stalk and a PCOM here. Now, always a tumor is attaching to the optic nerve very firmly, so we have to care everything, and we have to preserve all the vessels, every single arteries we have to leave, otherwise you can lose the visual function. There is the last piece on the stalk and on the tiny perforators. Okay, so we preserved the stalk. This is the last piece on the perforators. So now I'm removing it. and mostly the tumor, or the tumor is gone and preserved every artery. Okay, so I'm reconstructing this by continuous suture with fat graft and bony reconstruction, and in this case I used sphenoid mucosa. Okay, let's move to the lateral extension. If you want to go lateral, you have to drill the bony structure of the nasal cavity, which is orbital process is protruding from a posterior wall of a maxillary sinus. And sometimes the flow of posterior ethmoid sinus is obstructing the corridor to lateral. So in these cases, you have to do a lateral extension. So for the tumor, the pituitary adenoma, which is invading into the cavernous sinus. So maybe some amount of the tumor is resected with this approach. I show some example, the invading adenoma. So now I am drilling the left posterior wall of a maxillary sinus, and I remove the orbital process, the root of orbital process, and expose the sphenoparatine artery. And this is the sphenoparatine artery, and I'm drilling a little bit more beyond the sphenoparatine artery. So, and after some drilling of a bony structure around the sphenoparatine artery, we can expose the lateral edge of the sphenoid sinus. And this is a tumor covered with mucosa flap. So because the tumor is extending into the sphenoid sinus. So now I am cutting the tumor and the mucosa and started the compression of the tumor. Tumor is always soft and suckable, so I'm decompressing the tumor. And then gradually we go into the cavernous sinus, cellar and cavernous sinus. So now you can see the IC is running here. And from a medial, you can see the third nerve just medial upper area of IC. And there is many trabeculas inside the cavernous sinus. So all we have to do is just suck the soft tissues without cutting any structures, including a trabecula. Just suck it gently. So now I'm approaching to lateral to the IC from the anterior wall of the cavernous sinus. And now you can see the branching artery. This is the inferolateral trunk of IC. So now you see the IC and the branching of inferolateral trunk. And now you can see the sixth nerve is running lateral to the IC. And then I removed the soft tumors as much as possible and finish the surgery. And we could remove this amount of the tumor. And this is 6 months post-operative MRI. Okay, I show you another example of encephalocele for middle fossa and just lateral to the foramen rotundum. And now I'm approaching to lateral during the bony structure. And now I found the median nerve here. And in this case, I cut the median nerve. And beyond the median nerve, there's a brain tissue. And we cut the brain tissue and find a hole at the bottom of the middle fossa. And this is the V2 complex, V2 and pterygopalatine ganglion. And then we reconstruction of we have done a reconstruction of the this defect and finish. Okay, this is the last part of this presentation, the clival region, the clival tumors. This is chordoma. In this case, I drilled out and exposed the IC, and I removed the tumor beyond the IC, and I confirmed the sixth nerve, and I completed the. And this is the transdorsal approach for craniopharyngioma. And this, I'm removing the bony structure beyond the sella, and I'm cutting the pituitary gland, and I made a corridor to the tumor, and resecting the tumor, preserving all the vessels from beyond the chiasm. So I'm preserving the very small vessels as much as possible, and I'm dissecting tumor from the optic tract, and dissecting tumor from the brain, hypothalamic area, and I remove the tumor. Okay. This is the bony window after the surgery. This is the last case. This is a very tough case. After 6 years after the first surgery, the recurrence. So tumor is at the beyond the sella in a posterior fossa. So I drew out the clivus and removed the posterior columnar process. Then we made a corridor to the posterior fossa by drilling. Now I'm removing the posterior columnar process. And then we cut the dura mater. Okay. Okay. And now I am cutting the inferior hypophyseal artery between pituitary gland and cavernous sinus, and we made a corridor here to the posterior fossa. And now I am dissecting the solid enhanced part of the tumor just beneath the optic tract. So this is optic tract, and the tumor is hardly attaching. And this is solid part. We have to remove this part. This is solid part of tumor. After removing this part, you can reach to the posterior fossa. You can see the third ventricle, the mammillary body, and the optic tract. And so there's many cystic component, but we are searching the solid thick wall of the cyst. So now I am dissecting the solid part from the basilar artery. So now I am going to remove this part. Actually, otherwise there is a very thin membrane on the brain stem, so I left the thin wall of a cyst. All the thick component is gone, and then I'm doing the reconstruction. Okay. This is the post-operative MRI. This is the window I made in this case. All the clivus is gone. Okay, thank you for your attention.
Thank you for the nice presentation, Professor Watanabe from Nagoya University Hospital. To the audience, if you have a question or comment, please contact to the committee, and committee will send the email to Professor Watanabe. And then we will move to the last speaker, Dr. Indro Basuki from Gajah Mada University. We will talk about the health technology assessment and its impact on patient safety. Dr. Indro Basuki was graduated from Pajajaran University.
Oke, saya udah mulai. Saya udah ikut.
Dr. Indro. Thank you, Dr. Indro. Oke, mau online atau offline, Dok? Ya, maaf, mau online atau mau live, Dok? Dr. Indro mau pakai pre-recording aja?
Ya, sudah saya rekam ya.
Oke. Committee, please present the presentation of Dr. Indro.
Thank you very much. Good afternoon, dear colleagues. First of all, I would like to thank you to the organizing committee and also for the Indonesian Neurosurgical Society for giving me the opportunity to speak about health technology assessment and its impact on patient safety. This is my curriculum vitae. Okay, first of all, patient safety is the reduce and prevention of error and adverse effect to patients that are associated with healthcare quality. It is announced by the WHO. And patient safety now recognized as a priority by health system around the world. So everybody, every health care must be place the patient safety as a high priority. This is the scope of hospital risk management for the safety. Yeah, first of the patient, safety of the healthcare worker, safety of the facility, safety for the environment, and also must be safety for the business of the hospital itself. It's very complex scope for safety. So WHO World Alliance for Patient Safety scope are patient for patient safety, global challenge, safety research, reporting and learning, international classification system, and patient safety solution. In connection with the health technology, maybe the safety research will be take place prominently. This is a global techno industry for patient safety. There are nine focus for patient safety. For medicine, look alike, sound alike, medication names, patient identification, communication during patient handover, performance of correct procedures and correct body sites, control of electrolyte concentrate solution, assuring medication accuracy at transition in care. That's very important also. Avoiding catheter and tubing misconnection, single use of injection devices, improve hand hygiene to prevent healthcare association infection. So this 9 factor must be in a high priority for every healthcare. For us as a surgeon, there are universal protocol about 6 corrects. 1, corrects of the documents, correct of surgical site, correct of patient itself, correct of procedures, correct of body part, and correct for equipment. These are 6 factors must correct. So we talk about the health technology. Health technology is the application of organized knowledge and skill in the form of devices, medicine, vaccine, procedure and system developed to solve a health problem and improve quality of life. So this also include the traditional medicine, health promotion, prevention activities, and information system. So we're talking about the procedures and system developed to solve a health problem and improve a quality of life. What about the health technology assessment? This is a systematic evaluation of the properties, effect, impact of health technology. Purpose to address the direct, indirect, intended, and unintended benefit and consequences of the adoption of the healthcare technology. So we must assess the health technology we use for caring the patient in a short term, medium, and long-term evaluation by updating research for peer group. This is the responsibility of us as a professional surgeon to evaluate our works, short-term, medium, and long-term. And if the new technology is good for the patient, would be decided as standard operating procedures. So health technology assessment is a multidisciplinary activity, examines the direct and indirect effect of health technology on 1, available resources, 2, cost and cost effectiveness. 3, technical aspect, safety and efficacy. And 4, other aspect. This is very important. By examples, legal and ethical issues. So we have a Nuremberg Code of 1974 about one is voluntary consent essential. Second, must yield valid result. 3, based on animal experiment. 4, avoid physical and mental suffering. 5, avoid injury. 6, risk proportional to benefit. 7, subject must be protected. 8, qualified investigator. 9, voluntary withdrawal. And 10, must be terminated if necessary. So this code is very important, and we must be very careful to do the new technology in operation, in care of the patient, because we must follow this Nuremberg Code. It's very, very extremely careful, careful for the patient. So health technology goal for the clinical, we have to extend the life, cure rate, number of recurrence must be minimized, mortality must be minimized. For the economic factor, cost saving and cost avoidance. For the humanistic factor, we must aim to the quality of life and patient satisfaction. Health technology application in neurosurgery, we have tumor, vascular, pediatric, functional, trauma. The technology is already developed very highly and very sophisticated, and it's of course need special special skills and also equipped well for doing this operation. This is a brain tumor with neuronavigation. The development now use functional magnetic resonance imaging and a task developed to assess accurate selection between completing responses based on conditional rules. Preoperatively assess the function of PMDR in patient with brain tumor close to the region. Yeah, premature dorsal in patient with brain tumor close to the region. So the neuronavigation will be shift the function of our patient. Development of endovascular neurosurgery also very progressively and very nicely, but it took also must be with a very sophisticated instrument and also skills. Treatment of cerebral aneurysma is no longer limited to primary coiling. Yeah, this is the new development. Balloon, liquid embolic agent, and flow-directed catheter have revolutionized the treatment of arteriovenous malformation and fistulae. Very nice development of the endovascular neurosurgery. This is the development of pediatric neurosurgery, also developed very well. Need special competencies and also special instrument. To improve the quality of life, reduce mortality, disability limitation, and better outcomes if they are treated effectively. Now about functional neurosurgery, we have tractography, microvascular surgery. It's very sophisticated and also need competencies, special competencies. Functional neurosurgery also improve the quality of life, improve daily activity, and limitation of the disability. For the trauma, we have many new technologies. It's always need short-term, medium-term, and long-term research for its benefit for our patient. So this is the controlling and evaluation by peer group, by continuing research and case report for the short-term, mid-term, and long-term. So this is very important as our responsibility as a neurosurgeon to do the continuing research and case report by our peer group, short-term, mid-term, and long-term. This is the W Health Education Evaluation from WFO. Okay. So if everybody understand about its right and responsibility, of course, patient safety, doctor safety, healthcare and provider safety will be aimed very well, and we can make everybody happy. So thank you very much for your attention. I'm sorry if there is some mistakes in my presentation. Thank you very much. Good afternoon.
Thank you, Dr. Indro. Nice presentation.
Terima kasih.
We still have 1 minute for the discussion. As there are any comment or question from the audience? Atau ada komen, Dok? Monggo.
Saya hanya ingin menyampaikan bahwa that's our responsibility to recheck and check about our activity in neurosurgical works, especially about the very, very new technology. Must be really our responsibility by its peer group to evaluate which the technology is effective or not for our patient, make our patient happy, make our patient more safety, and also make us also happy if the patient is correctly treated. Thank you very much, Doctor.
Okay, thank you, Dr. Indro. Nice message to us that we should keep in mind. Time up. Thank you for the all speakers that already present the committee, and now I finish the session. Thank you for all the participants. See you for the next presentation in room. In the next session, we'll wait a minute. In the plenary 5, yeah. will be moderated by Dr. Nyoman Golden. Okay, thank you. See you and sehat selalu. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you very much.
Thank you, Dr. Tohar.
Thank you, Dr. Tohar.
See you, Dok.
Iya, sami.
Thank you to all speakers for an amazing information and Dr. Muhammad Tohar Arifin for leading this session. Distinguished guests, speakers, delegates, ladies and gentlemen, now we move on to the fifth plenary lecture with Dr. Nyoman Golden as a moderator. Before we start this session, please allow me to read his CV. Dr. Nyoman Golden was completed his medical studies at Gadjah Mada University in 1988. Dr. Golden became neurosurgical consultant at Erlangga University in 1996. In 1996, he also participated in fellowship microsurgery program at Sir Charles Gardner Hospital, Australia. He continued his fellowship microsurgery program at Nagoya University, Japan in 1997. He's also participated in fellowship microsurgery program at Fujita Health University, Japan in 1998. Dr. Nyoman Golden was completed his doctoral studies at Udayana University in 2009. It is the short CV from Dr. Nyoman Golden. And now I hand over the session to Dr. Nyoman Golden. Time is yours.
Thank you for the committee for giving me opportunity to chair the session. There will be 4 speakers. I hope that all the speakers get ready for their presentation. The first speaker is my mentor, Professor Hafid. He's a professor of neurosurgery at the Erlangga University. He is now is the chairman of our society. I think we all already know very well him. No further introduction is needed. Please, I kindly invite Prof. Hafid to share your lecture today. Time is yours.
Yes. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Thank you very much. Thank you, Mr. Moderator, Professor Nyoman Golden, and thank you, the co-moderator and all the organizing committee. Thank you very much, Dr. Rohadi, for this beautiful and excellent meeting. I will present, I will share now my, can you see my slide?
Yes, Professor.
Just make a slideshow.
Okay.
Okay.
My title is Management of Delay Cervical Stenotic Myopathy. Now, cervical stenotic myelopathy is a degenerative process. It can cause by, beside degenerative, also by OPLL or OLF. Degenerative process of spondylotic spondylometaphy is a broad variety of degenerative changes of the extradural spinal tissues that causes compression to the spinal cord and surrounding structures. The magnitude of the problem is it is most common in men aged 55 years older or older. And overall incidence is increases, and GSM is the most common cause of neurological dysfunction in the world. The number of patients undergoing surgical treatment each year is increased up to 7-fold. Now, the most patient comes to surgeon in delayed condition because it's treated conservatively for many years. The patient came with multi-level and complex pathology, 65% with symptom duration more than 12 months, a clear picture of myelopathy, and 40% accompanied by loss of lordosis. This is the changes of pathology you can see: osteophyte, disc protrusion, hypermobility, listhesis, OPLL, thickening of flavum and bulking, cord compression, and loss of lordosis. This is one of sample of this patient. This is a complicated pathology or delay cervical myelopathy stenotic. Now, the intervention for this kind of disease is the primary aims is to decompress the spinal cord, especially optimal alignment correction and maintain stability. The secondary aim to minimize the complication, especially the sensory impairment, which is very disturbing for the patient. The goal of surgery is can be done decompression of spinal cord by anterior or posterior, and deformity correction by fusion and instrumentation. Now, the selection criteria is important to see what is the sagittal profile, what is the there is instability or not, what about the bone quality, what is the level of infected, and the sort of stenosis. From this, then you can see you can choose which kind of approach you will be prefer. Which one is better actually, anterior or posterior? Actually, for multi-level cervical myelopathy, there was no apparent difference regarding the neurologic recovery and the effectivity. Anterior approach has its indication where surgeon experience is important to determine which approach is the best for the patient. Every approach has its own benefit and weakness. I will let's see you the guideline now. You see if there is an stenotic not more than 3 level, it can be possibility you can do anteriorly. But if there is more than 3 level, then with axial pain, then you can choose only anterior approach of laminectomy infusion. If there is no axial pain, that is more than 3 level, then you can see if whether there are significant stenosis or not. If there is no significant stenosis, the patient is still in neutral and not lordotic, normal lordotic, then you can choose laminoplasty. So if there is a mild or moderate kyphosis, but it is correctable, then you can do laminectomy infusion. But if there is significant kyphosis, then the patient, if there is an already laminectomy before, then you have to choose HCDF, corpectomy or fusion. Or if there is no laminectomy before, also you can choose laminectomy fusion or corpectomy. No laminoplasty in this case. Now, in multi-level stenotic myelopathy, this is indication, special indication for anterior approach, like this is the pictures. This is not more than 3 motion segments involved. Significant kyphosis, you can see the significant kyphosis. Maybe there is an axial pain also, a failed laminectomy previously, or there is an OPLL with heel shape lesion. I will let you see later. And high compression ratio. Posterior approach, it consists of laminectomy alone, laminectomy with fusion, and laminoplasty. Cervical laminectomy is the oldest procedure described for the compression of the cervical spine cord. Cervical laminoplasty is canal expanding procedure to preserve motion in the cervical spine. The advantage is posterior, is the compression is easier and achieved and wider, less risky procedure because there is no carotid, no trachea, no larynx, no pharynx, no thyroid like this. So easier is again from posterior. This is anterior. You have to do through the many important organs. Now requires a minimum graft for posterior, no risk of graft dislodgement, low risk of adjacent segment degeneration, low risk of bleeding, shorter operation time, and less risk of for older age. Now, disadvantage of posterior is it didn't remove anterior pathology. It's just only decompress. The wound complication is higher. The patient often complain of neck pain. This is the disadvantage. limitation of posterior also for fixed kyphosis, then this patient often requires circumferential approach, anterior and posterior. If there is a permanent cord injury, intermedullary abnormality, it is no use for the compression of this kind of approach. Now, this is laminectomy alone. This is no longer used because there is a late segmental instability, post-laminectomy kyphosis, perinealar scar, loss of cervical motion, and delay neurological. Nowadays, due to this complication, laminectomy with fusion or laminoplasty has replaced simple laminectomy for posterior procedure. Now, let's see laminectomy with fusion. It uses lateral mesh screw or pedicle screw. The indication in multi-level cervical stenotic. This is 3 or more level stenotic. It preserves lordotic, reduce residual cervical kyphosis. Even if there is kyphosis, but you can reduce it with the flexion extension X-ray. You can see that. And to stabilize in clinical and subclinical instability, you can use laminectomy and fusion and allow reliable new bone formation around a stable scaffold. Now, advantage of laminectomy and fusion is prevent occurrence of post-procedural kyphosis, improve instability if the patient has undergone laminectomy or profuse decompression procedure, reduce repetitive microtrauma effect, and good clinical result. This is also an alternative to standalone laminectomy or laminoplasty in multi-level disease, those with residual cervical kyphosis. This is a patient with a pre-op Japan orthopedic score with 6. You can see the multi-level. Yes, this 3-level, loss of lordosis with kyphotic. And this is the MRI. You can see also there is an myelopathy sign. What will you do? This is patient with flexion extensive. There you can see the residual kyphotic. Then you can choose this laminectomy and fusion. And for this kind of PLL, you can see the laminoplasty. This is started by Japanese surgeon in 1970s. And this is alternative treatment considered not to be done if there is cervical kyphosis or preoperative axial net pain, not to be done in this case. Advantage of laminoplasty, lower incidence of complication, able to expand the spinal canal, able to avoid occurrence of post-laminectomy membrane complication, and suppress the number of even of dural tears, reduce the risk of adjacent segment degeneration, and preserve posterior structure, and can be done together with fusion. It is always considered risk of kyphosis in post-laminoplasty. Even you do laminoplasty, there is still possible progressing of kyphosis. So not recommended to do laminoplasty in a case like this with kyphosis more than 18 grade or more than 5 grade with signal change of the cord. In this case like this, even this is a slight kyphosis, you can still, we cannot do laminoplasty. And this is the last, in the last picture, which there is a segmental instability, you cannot do laminoplasty. Also in heel shape OPLL like this, you not, it is contraindicated for laminoplasty. Now, if there is a patient with 3-level stenotic, slight kyphotic with instability, 2-level instability like this, what the possibility? Never doing laminoplasty, and you can do anterior approach, okay? But if dynamic function is still good and posterior laminectomy, posterior laminectomy fusion, you can do better for this patient, okay? And the case like this, loss of lordosis, more 4-level, lateral X-ray flexi extensive, slight flexible. Can we do anterior approach? If the patient old age and more than 3 level and may need corpectomy, then don't do anterior. How about the laminoplasty? If there is a neck pain of risk, if composite will be more progress and don't do laminoplasty. So they prefer use this laminectomy infusion for this case. Pre-op evaluation, important thing is axial CT scan to see the mesh, how big is the mesh for placing of lateral mesh screw, and how about the instability, about the kyphosis. You can see the kyphosis residual or not. If there is not residual, don't use laminoplasty. Patient can do prone position or not. Is there an axial neck pain or not? If there's an axial pain, don't do laminoplasty. Let's see meta-analysis between laminoplasty and laminectomy infusion. Then the result is that both were determined to be effective, but laminoplasty allow greater range of motion, lower overall complication, especially C5 palsy, shorter operation time, and lower of blood. In this case, this is similar term of most clinical outcome. However, a higher complication rate was found in laminectomy infusion group and significantly higher nerve palsy in laminectomy infusion group. So it depends on the condition. And this is anterior decompression combined with posterior decompression. Anterior better preserve post-operative cervical lordosis, but anterior has associated with greater surgical invasion and high incidence of surgical complication. How would the factor to be considered in choosing laminectomy fusion and laminoplasty? Let's see. First, you have to see the less number of level involved. If there is more than 3 levels, you can choose laminoplasty or laminectomy. If not more than 3, then there is still possible for anterior. See the curvature, sagittal. Is there is still normal lordotic, you can choose laminoplasty and laminectomy and so on. Now, what about the combined approach anterior and posterior? This is only for complex cervical stenotic myelopathy. You can see this is a complex cervical myelopathy. You cannot use just only laminoplasty alone or laminectomy and fusion, but you have to choose a combined approach. So combined approach is used if there is a significant ventral and dorsal compression and cannot be handled only for one anterior or posterior approach. It is better to maintain the sagittal alignment and higher fusion rate and low incidence of complication, and better clinical outcome in case of significant kyphosis if you do combined approach. The fusion rate with combined approach is 90%. So this is a man with 57 years old with significant myelopathy. Japan or Orthopedic Association score is 6. And then this patient, you see the myelopathy. You see, this is a flexi extensive. There is a slight kyphosis, but there is a fix here in 2 levels. There is a fix of movement here. Then we use combined because we do ACDF in the anterior. So what about combined approach consider, especially in severe osteoporosis, heavy smoker, significant kyphosis, multi-level decompression? The disadvantage is the technique is difficult, higher operation time and blood loss. And the conclusion is that posterior approach for more than 3 levels is better. You use laminectomy and fusion and or laminoplasty. Always case-by-case evaluation based on clinical radiologic characteristic in individual patient, not on preference of the surgeon only. Most cases can do laminoplasty and but for residual kyphotic cases require laminectomy infusion. fixed kyphosis should be done anteriorly or combined. Significant ventral and dorsal compression should be done combined approach. Thank you very much.
Thank you, Prof. Hafid, for your great presentation. In my opinion, what you have given to us, that there are two big issues in this problem. First, that the late of patient to be presented to the proper surgeon, and the second one is that the choosing of surgical approach in such difficult case. And it has been proven that early surgery will give much better outcome. So the problem is the awareness of our physician, of our other specialists of this problem. Even in developed countries, they have also that delay because maybe of the referral system that they have. First, patient have to come to the general physician and the care for many visits, and then finally they come late to a proper surgeon. The second is the choosing of surgical approach. This also need to be tolerated with the patient condition, surgeon experience, and many things that to be considered before embarking this surgery. I think this is my comment on your lecture for Hafid. Is there any question from the floor or from the audience? The question can be directly to Prof. Hafid or can be chat in the chat column.
Yes.
Can the committee to unmute the participant to address a question directly to Prof. Hafid? Because I don't see any question in the chat column.
I'm sorry, Professor Golden.
Yes. Okay.
So if there are any question, they can activate the microphone.
Okay, I hope that there will be question from the participant, because we still have a time to for the question in this meeting. Okay, if there is no question anymore, anyway, thank you very much for your great lecture, Prof. Hafid. And I will move to the next speaker. Please make sure for the committee if the next speaker is there, or we have to go to the next speaker. The next speaker will be Professor Nagatani. I invite kindly to present his lecture.
Excuse me, sir.
Yeah.
I'm from the local committee because the Dr. Tetsuya Nagatani is can attend the Congress. maybe we can skip, and now we can give a chance for the Prof. Zainal Mutakin.
Okay, thank you. So I will skip the Professor Nagatani, and I'll move to the next speaker. So next speaker will be Prof. Mutakin.
Okay.
Prof. Mutakin is a very well-known epileptic surgeon and neurosurgeon in our country. And he's a professor at the University of Diponegoro. I think we have already known him very well. No introduction is needed anymore. Please give your lecture. Time will be yours.
Thank you very much, Professor Norman Golden. Yeah, for the committee also, thank you very much for giving me opportunity to present my work in this very special meeting. So let's start. I have given the committee about my video, and please we'll discuss it later. Please start the presentation. Dear colleagues, ladies and gentlemen, today I would like to thank the committee of this Congress for inviting me to talk in this symposium. I would like to talk about how to start epilepsy surgery program in limited resources. About 30% of people with epilepsy will continue to have seizures even with any anti-epileptic medications. We call it refractory epilepsy. And more than half of these refractory cases might be cured by epilepsy surgery. According to WHO report in 2019, that there are so many nations in Asia that do not have any epilepsy surgery program yet. The epilepsy surgery is still underutilized in most Asian countries. This underutilization is mainly caused by lack of expertise, lack of facilities, and lack of fundings. Epilepsy surgery means surgery to abolish seizures. Epilepsy surgery aims at complete resections of or disconnection of the epileptogenic zone with the preservation of the eloquent or functionally important cortex. To reach these goals, we need diagnostic tools for localization and boundaries of the epileptogenic zone. We call it pre-surgical evaluations. Consists of analysis of seizure semiology, electrophysiological recordings, neuroimaging studies, functional testing, and neuropsychological assessment. The main purpose of surgery is to abolish seizures, to reduce seizure burden, and to improve quality of life. In certain type of epilepsy, such as temporal lobe epilepsy, the chance of seizure-free will be about 80 to 90%. This is the first randomized controlled trial on epilepsy surgery for temporal lobe epilepsy, published in 2001 by Professor Weber in New England Journal of Medicine. It shows that for refractory temporal lobe epilepsy, surgery is superior, 64% seizure-free compared to optimized medical treatment, which is only 8% seizure-free. In 2017, another proof shown by Professor Manjari from Delhi, India, in New England Journal of Medicine. This center works on children under 18, and the waiting list for epilepsy surgery is more than 1 year. So, they use those who are waiting for control group. And the result shows that the children who already had surgery has the seizure-free rate more than 77% compared to those who still under medication, the seizure-free is only 7%. Let's see how big is the problem in Indonesia. With more than 260 million population, we have at least 2.5 million epileptics. Among them, about 400,000 are candidates for epilepsy surgery. And for the last 20 years, starting in the year of 2000 until now, there are only 800 cases of epilepsy surgery performed in Semarang. It's still nothing compared to 400,000. From those operated in Semarang, about 40% are coming from Central Jawa. And another 40% comes from Jawa Island, West Jawa, East Jawa, Jakarta and surroundings, and Bali area. How about people coming from other islands? So it means that we should start surgery in many other centers in Indonesia. There are facts and fakes regarding the epilepsy surgery. There is common opinion that epilepsy surgery is expensive. It is wrong. There is opinion that epilepsy surgery needs so many advanced pre-surgical investigations not easily provided in developing countries. It is not always true. Only few cases needed those examinations. There are problems in health insurance coverage in many countries. People should pay for the health services by their own. Most private insurance do not cover epilepsy, mainly related to the hereditary in parentheses reason. It is true. And epilepsy is not the major health issues in many countries. There are still other health problems such as famine, infection, and communicable diseases. It is true. And so, initiative regarding epilepsy surgery should be pushed by local neurological or neurosurgical society. In fact, any hospital with micro-neurosurgical facility, with MRI and EEG, and the neurologist, neurosurgeon interested in epilepsy surgery, it is more than enough to start epilepsy surgery program. The main reason of the delayed referral or underutilization of epilepsy surgery lies on absence of epilepsy surgery facilities, so that among GP and neurologists, there is lack of understanding about epilepsy surgery. They never meet in person with cases of patients after the surgery. And this lack of understanding, lack of exposure causes exaggerated fears regarding the complication of epilepsy surgery. And the end result is non-referral or delayed referral of epilepsy surgery cases. We start our surgery in the year of 2000 with simple temporal lobe epilepsy cases. Simple means that those patients had classic semiology of the temporal lobe epilepsy, and on MRI we found lesion unilateral in one side of the temporal lobe. And later on, after 5 to 6 years, we work on more difficult cases. And for the last 10 years, we perform more than 50 to 70 cases of epilepsy surgery every year. How to start? Traditionally, people with epilepsy are treated pharmacologically by other physicians. The resistance against neurosurgeons involved in the treatment of epilepsy is high sometimes. In fact, less than 10% of our surgical cases that were referred by their physician. Most of them heard about the epilepsy surgery from the social media or from the experience of other epilepsy patients. So that we need to show good surgical result with good seizure elimination rate and near zero morbidity. We should start with simple temporal lobe epilepsy cases with classic semiology, and the MRI shows unilateral temporal lesions. We should work together with our radiologists, to make protocol for temporal lobe epilepsy, for frontal lobe epilepsy, so that the imaging will show some of the lesions. We should present our cases, surgical cases, to as many local physicians meeting, especially the neurological meeting and the pediatric society meeting. We should also work with social media owned by people with epilepsy. And then how to find the candidates. There are 3 ways. First, we should find out the temporal lobe epilepsy from the semiology and the classic semiology of the temporal lobe, and then the history of the medication, and last but the most important is imaging. It means MRI. There is no place for CT scan on epilepsy imaging. Most of the cases are temporal lobe, mesial temporal lobe epilepsy cases. But there are also lesional epilepsy, vascular lesions, benign glioneuronal tumors, and cortical dysplasia. There are also catastrophic epilepsy in children, especially related to the hemispheric syndromes. From our cases, most of them, 80%, are temporal lobe epilepsy. And for the first few years, we work only for those cases with lesion or abnormality on MRI. But recently, we also work for those cases with normal MRI. We decide the site of the focus from the long-term EEG, PET scan, and even intracranial invasive EEG. What is temporal lobe epilepsy? The lesion we will find in the hippocampus mostly. And in temporal lobe epilepsy, the surgical approach is a standardized anterior temporal lobectomy. So any investigations, the aims is to find out the site of the epileptic temporal site. MRI, even the most simple 0.3 Tesla will find out the sclerosis in the hippocampus using specific protocol. If we have better 1.5 Tesla or 3 Tesla, we will be able to do quantitative study, or we take a look at the internal structure of the hippocampus. For the first 5 to 6 years, we perform 56 cases, all temporal lobe epilepsy, and almost 98% depends on imaging. The concordance of the semiology and the lesion on imaging. There are so many evidence, including our own published, that shows that the possibility of doing epilepsy surgery based on good MRI, routine EEG, and detailed seizure semiology. And for temporal lobe epilepsy with unilateral hippocampal sclerosis, anterior temporal lobectomy or selective amygdalohypocampectomy might be done with good result without investigations, 'for seizure focus. From the first few years, we learned that temporal lobe epilepsy with concordant unilateral hippocampal might go directly to epilepsy surgery without any difficult pre-surgical evaluations, so that any center with microneurosurgical facility, good MRI and EEG with neurosurgeon and neurologists interested in epilepsy surgery is more than enough to start epilepsy surgery. Epilepsy surgery is a teamwork. All cases are discussed in the team. All team members should learn to be an epileptologist. It means understand seizure semiology, the aim of each kind of pre-surgical evaluations, and understand about neuroimaging in epilepsy. And the hospital should start with an epilepsy monitoring unit, EMU. The patient may be admitted to the hospital by neurosurgeon, neurologist, or the pediatric neurologist, but all the patient goes to EMU that never stops working, at least for long-term video EEG. After more than 5 years, we start working on difficult and complex epilepsy cases. It is temporal lobe epilepsy with doubtful laterality, with normal MRI or bilateral sclerosis. Temporal lobe epilepsy cases with discordant result of seizure semiology, MRI or the routine EEG findings, and temporal lobe epilepsy with double pathology. And also extratemporal lobe epilepsy cases and other surgically treatable epilepsy cases such as atonic epilepsy in children with drop attack and catastrophic epilepsy cases in children involving one hemisphere. Doubtful semiology not resolved by ictal EEG or extratemporal cases who might need invasive EEG or intraoperative electrocorticography. This is a young girl with refractory temporal lobe epilepsy with bilateral hippocampal sclerosis. Sure that we need ictal long-term EEG to decide which temporal site are the primary focus. This young boy with suspected of having left frontal lobe epilepsy also needs long-term video EEG to decide exactly where the epileptogenic focus comes from. This young boy had temporal lobe epilepsy semiology but with completely normal imaging on MRI. The PET-CT studies using FDG shows that the right temporal is clearly hypometabolic. So we did right temporal lobectomy on this case with seizure-free. This case of frontal lobe epilepsy involving near eloquent cortex always needs electrocorticography during the surgery to decide the border of the resections and also for cortical mapping of the eloquent cortex. If the lesion is still doubtful, we put also intracranial invasive EEG in subdural space and we monitor for 2 to 3 weeks before deciding the surgery, and we still use ECOG during the surgery too. This 4-year-old young girl had seizures since the age of 2 months old. Looking at the seizure semiology, it seems there are 2 different types of seizures. One that suspected comes from the right hemisphere. It is more often and shorter duration, and another one that comes from the left hemisphere. It is longer duration, but not as often as the first one. So we decide to put intracranial subdural grid electrodes to both sides of the frontal lobe and both sides of the temporal lobe in this 4-year-old girl. We suspected from the neuroimaging the presence of heterotopia in the right frontal regions. So finally, we decided to do right frontal lesionectomy guided by electrocorticography and combined with left anterior temporal lobectomy in this young girl. And the result shows that Angel's class 2, almost seizure-free. After working for more than 10 years on epilepsy surgery, we learned that to improve result of epilepsy surgery and to manage difficult cases, we should develop pre-surgical evaluations with long-term video EEG, better MRI, PET-CT study, neuropsychological batteries, and also invasive intracranial electrodes or electrocorticography. A successful epilepsy surgery program needs a team consist of EEG nurse, neurologist, pediatric neuroradiologist, neuropsychologist, neuropsychiatrist, and even neuropathologist also. To gain acceptability of epilepsy surgery from other physicians, we should present our epilepsy surgery cases to as many local or regional physicians meeting, especially the neurological and pediatric neurological meetings. We work also with the groups of people with epilepsy. We make video vlog, we discuss about epilepsy surgery and the result of surgery in the radio, local television. They upload this vlog to YouTube. It will be seen by those people with epilepsy which need surgery. After working with all difficult epilepsy surgery cases and doing all kind of difficult pre-surgical evaluations, we still found that for temporal lobe epilepsy cases, still about half of them are simple temporal lobe epilepsy cases which needs only good imaging and EEG besides seizure semiology. From all of our cases, almost half are simple temporal lobe epilepsy cases, and only less than 20% cases that needs invasive studies. Seizure-free or Angel class 1 is almost 80% in simple cases, but still good enough even for difficult cases. After about 20 years of experiences with about 800 cases of epilepsy surgery, these are some of our publications for the last 4 years. In conclusion, about 30% of epilepsy will be refractory. Most of these refractory cases are temporal lobe epilepsies, and almost half of them are simple cases that do not need any difficult investigations. Hospital with microneurosurgical facilities with neurology and neurosurgeon interested in epilepsy surgery should start surgery for simple temporal lobe epilepsies. And next step is developing the epilepsy surgery team, including EEG nurse, and setting an epilepsy monitoring unit at the hospital. And finally, we should also create as many education material regarding epilepsy surgery, involving people with epilepsy to share their pre- and post-surgical experiences via social media is more important too. Thank you very much for listening.
Oke, terima kasih sekali atas perhatiannya. Semoga bisa menginduksi para sejawat lain di berbagai daerah di Indonesia untuk menginisiasi, ya. Kami siap untuk mendukung tim kami di Semarang, siap untuk datang ke center manapun untuk mendampingi, ya, siapapun yang berminat untuk mengembangkan bedah epilepsi di center-center yang ada di seluruh Indonesia, khususnya di wilayah yang belum memiliki center yang melakukan bedah epilepsi. Sumatera, Kalimantan, Sulawesi, Nusa Tenggara, ya, dan Papua. Kami siap agar semua penyandang epilepsi yang kebal obat bisa ditolong dengan pembedahan. Begitu Pak moderator. Pak Nyoman, silakan.
Thank you for great presentation. I have some opinion probably in this case. First, in selecting a patient, we need a team. That's also the problem in our hospital. It's not easy as you say that in obtaining or in selecting the patient, and we need teams. Probably the surgery is not complicated, but hello.
Ya silakan suaranya. Ya, oke. Ya, so we know that epilepsy is treated until now by neurologists and pediatric neuro and general physician. So we should make a lot of meeting we should join their local meeting. Even just showing a poster about epilepsy surgery. And then what we start in Semarang, we send our young neurologists and young pediatrician to stay for 1 to 3 months in epilepsy center abroad. So they learn about the concept of epilepsy surgery. We should send them abroad to open their minds about epilepsy surgery. Without that, it is difficult to ask them to think about epilepsy surgery. But in our hospital in Semarang, almost all the pediatrician, the neurologists are now understand about what we are doing. We are part of the team. They are part of the team. We should make a lot of discussion with them. I think that's for the start. But at least we should start, because without any neurosurgeon interested in epilepsy surgery, there will never be any epilepsy surgery without neurosurgeon. The patient might come from anywhere. If at least you have a patient, you just discuss with us, via online, via video call, via internet, email, and if it is there is indication for surgery, we should show them that we are able to do epilepsy surgery to help the patients. Just one case is enough, 1 or 2 cases operated in your center. We will come to accompany you. That's for the start, because we do it in Jakarta already. We do it in Jakarta, in a private hospital, at Bunda Hospital in Jakarta with Dr. Ibnu Ben Hadi, our colleague there, starting 3 years ago, and now they have performed more than 20 epilepsy surgery cases there. We are coming there to accompany them. We should start first, shows the medical society that we do it and with good result. We should make them sure that the result will be good. So start with simple temporal lobe epilepsy cases. That's the most important. With near zero surgical morbidity and the seizure elimination rate is more than 80%. Okay, Dr. Nyoman Golden that.
Thank you.
Yeah.
That find the neurosurgeon who interested in this field. That's also a big issue. And I think how about making a center of excellence? I mean that the certain center has to be a center for the epileptic surgery.
Yeah, but take a look. Among 800 patients, 40% from Central Java, from Jawa Tengah, another 40% from Java Island. Operation is paid by BPJS, but how to make them come to our center? It is difficult problem for the patient and the family. Stay about 1 to 2 weeks at least. It needs a lot of money for that, not for the medical treatment. The treatment is paid by BPJS. So it is difficult. We have 400,000 epilepsy surgery candidate the whole Indonesia. We have performed only 800. It means nothing. So in educational center in IPDS, especially at Sanglah, at Medan, Sumatera Utara, at Sulawesi, Makassar, and in Kalimantan, maybe, East Kalimantan, they should have appoint one doctor, one neurosurgeon, young one. Please appoint them to learn. It doesn't have to work on epilepsy only. They may do any neurosurgical operation. I still do, skull base, brain tumor, but you should understand. They should understand the concept, the way how to make decision, what to do, what kind of surgery, what kind of examination is needed to make sure the focus is there. So please appoint one neurosurgeon first, and then if possible any young neurologist working in the same hospital, they may comes to learn with our neurologist in Semarang. Just that. Saya rasa if only Semarang or Jakarta, or I'm sure it will not change the demographic situation. Why Central Java for 40%? It doesn't related to so many epilepsy cases in Central Java. No, because the facility is here in Central Java, so it is easier for them to reach us. Saya rasa itu. That's I think we should think about that.
Thank you. I hope that the young neurosurgeon will more interested in epileptic surgery.
Yeah.
If there is nothing to be discussed, I think I'll move to next speaker. Next speaker will be
Professor.
Okay.
I just want to inform you that there's new schedule for us.
Okay, yes.
Okay. Oh,
Nakatani Sensei.
Professor Nakatani.
Yes, thank you very much. Yes.
Welcome.
Shall we start my lecture, okay?
Yeah. Just
Yes.
full screen.
Yes, okay, yeah. So my topics today is endoscopic approach for the cera and paracera regions. So today I will mention the very basic contents. Yes. So today I have two sections. In the first half, so I will speak anatomy and techniques for transfemoral approach as a historical point of view, and some dedicated tools. And the latter half, I will mention about the some important pathologies. I selected today is huge adenome and microadenome, especially the functioning adenome. So first, I will go to the first issues. As you know, we have two giants. The one is, of course, the cussing, and another is Hirsch. You know, the Hirsch is originated from the ENT doctors in wind. At the same time, they developed the transthyroidal approach for pituitary regions. And but there are very interesting contrasts between them. So Professor Cushing was aimed to the radical excision of the tumors, but Professor Hirsch was stick to the minimally invasively. So the most importantly, the Hirsch did this surgery with local anesthesia for 2 days long. So he used the trans-ethmoidal or nasal approach like ENT doctors now. So very similar method. But Professor Cushing stopped this approach because this limited exposure did not allow him to use bovine electricity to do the more complete tumor resection. So Cushing moved to the transcranial approach later. But this method moved to Europe and was cultivated by two giants, Professor Guillot and Professor Dot in England and French. And later, Julius Hardy had learned these techniques and took these techniques to the Canada and America. This is very popular history about the transthyroidal surgery. So the Hardy used the microscopic operating microscope and fluoroscopy, which were the latest equipment at that time. And he was doing the selective tumor resection to leave the anterior lobe functions. So, and also he created some tools, some dedicated tools. His method was very so sophisticated that for a long time this method was the golden standard to approach the pituitary regions. But in 1997, Professor Zhou reported 50 cases of the pituitary regions which were treated by purely endoscopic approach. So this paper was very, very striking for me, for us, and encouraged us very much. So we went to this field at that time from the 1997s. But we have very big problem. The endoscope has a potential benefit of panoramic view and higher magnified by closing. So very good visibility, but there are lack of stereotaxy, and big problem is conflict between tools and scopes. So we found it has a very less maneuverability. So to overcome this problem, we created two issues to be solved. The number one is technical aspects, how to create a wider surgical field. So we made a concept of wide sphenoidotomy. And the second instrumental aspects are the thin and flexible tools we need. So at that time, we started to progress dedicated tools for purely endoscopic procedures. This is a surgical view from the early period till the 2001. So at that time, we used the nasal spatula. So only open the anterior walls of the sphenoid sinus very partially because of the limitation by the using the nasal spatula. So we changed the method. Only use the nasal spatula at the early stage. So we remove this nasal spasma later. And then we drilled here the Bowman bone, the inferior part of the Bowman bone, we drilled out. So we created this area to obtain the wide surgical field from the 2002. As shown like this schema, we went into the nasal cavity to the bottom of the sphenoid sinus at this from this period. So as in the coronal plane, one important landscape mark is Bilian canal here. Between them, these width is the most wider at that in the sphenoid sinus. So Professor Kassan called this pterygoid wedge. This is very important landmark for this approach. So then now our concept full sphenoidotomy means opening the more sphenoid sinus as seen this here and here. This is the partially posterior ethmoidectomy. In most cases, we add this techniques. So you can obtain the very big and sufficient surgical field. The next, we are heading the progress the tools. So our philosophy that this grand design and idea tools. Number one is the tools it's basically straight tools, and number two but the moderately curved with body and tips, and also this tool should be maneuverable but with some rigidity, yes. And number four is the tools by means of rotating movement, like this tools. So, because what can I do through this approach is very limited, so we cannot so big space to move these tools. So rotating movement is very important. So these kind of tools is very useful for us for this kind of surgery. And also finally, the design should be simple. So this is our concept of this tool, of the tools. So more tools I will present. This is a suction tool. We have many kind of suction tools, but each has a moderately curve. These curves is helping us very much, yes. And also we recently progressed some tools like this rotating and fine forceps. You can see this tool can be rotating using this dial. So the tip of the forceps is very fine, and it is very useful the surgery of the extended transfemoral surgery, like meticulous procedure like meningioma or craniopharyngioma. So, and also these tools is very helpful for me to dissect, to assist us very much. So current standard surgical equipment and setup is here. For scope, we use the 4 millimeter rigid scope, 0 degrees, 30 degrees mainly, but sometimes we use 40 or more higher degrees of endoscope. So, and we used normally the high vision camera with 2 monitors. One is for the operator and one is for the assistant. So also we normally use the navigation systems and monitoring VEP, and also these tools we use. And our method is to fix the endoscope with such scope holders. We have 2 types of scope holders. Usually you use this type Uniarm from Mitaka company. Yeah. This is a video during the surgery. So this method, they for education also, educational meaning. So because the operator is here, so assistant helps him to teach how to do it, how to handle this area. This is our basic styles, so-called 3-hand techniques. So operator is training here, and assistant is trainer. So our outcome of non-functioning as norm from 1998. So initially we have only the 35% it achieved totally removal, but from the 2002, the number is getting better. So now around the 70% we perform the total removal for non-functioning adenomas. So this outcome is very stable, around about 10 years. So next, we move to the technical illustration for important pathologies. The first, huge adenoma. So the strategy is for huge pituitary adenoma here. So number one is transthyroidal. Most of them can be managed by only transthyroidal. And sometimes we use transcranial or staged surgery. But now we have simultaneous transthyroidal and transcranial combined surgery from 2002. Because of such a big pituitary adenoma, often resulted in this. This is our first case for the combined surgery. Fortunately, we achieved a good result for this case. And you see that the post-operative hemorrhage is reduced from the 2010s, about 14%, 40% to 14%. So no visual deterioration after the 2010 because of the introduction of this approach. For instance, these kind of tumor are very big, over 5 centimeters, but this tumor is very simple style, simple shape. So such kind of tumor can be managed only one transthyroidal with the sometimes extended what we need, but most of them can be managed on single surgery. Of course, this surgery is extended. So after this surgery, the patient condition is very good. So adding that the tumor embedded to the IC and optic nerve, like grade E, grade D. For the selected case, we use the transcranial and transnasal combined approach. We prefer to use the keyhole approach for transcranial side. So we have 2 monitors and 2 surgeons and 1 conductor modulator to see the both surgery. So they do that surgery with combination and so conductor says and we cooperate one tumor from two sides. This is one example. The tumor is like this, so we use this surgery, this approach. This is the endonasal part. This is the transcranial part. This side is a keyhole, a supraorbital keyhole approach. These two surgery, it cooperates to remove this mass. So most of the tumor can be removed through the endonasal, but we need assistance from the transcranial side. This is a key point of this approach, this surgery. After that, we perform the SRS to control this tumor. So for the microadenome, the microadenome is still a big challenging. I think it's not so easy. For this is a very typical case of the acromegaly case. Actually, this patient has gigantism, 18-year-old female. So the extracapsular approach, extracapsular excision technique here. So very important is to cut the dura very, very carefully, not to go inside the tumor first, and to find the tumor capsule first. To find the pituitary capsule first, and then remove or cut the normal, and to find the tumor capsule. So after cutting the meticulous fashion, that is very, very important point. And this is a pituitary capsule, and then first we cut a very tiny incision, and this is a normal pituitary gland, and to find this here, the tumor capsule. So once you find the tumor capsule, please keep this lumen and not lose this during the surgery. For such kind of tumor like this size, can be removed one piece, and soft you pull out the tumor. So the tumor can be removed one piece. So yes, is a little bit difficult, but very important. Also very important techniques. This is a paroxysm, but no tolerance for the drug. So we decided to the surgery. Here, this is a tumor invasion here. And first we remove the tumor as the fashion like this. And then we remove the major wall of the cavernous sinus. Of course, the breathing from the cavernous sinus is like this, but that can be controlled using some material. So after the surgery, the production level is below 5 nanogram. So in conclusion, as a take-home message was skill acquisition to have comprehension of anatomical structures and to create and keep bloodless surgical field is very important. And to select the optimal approach and tools to individual cases, and to perform safe precision as microscope study, so-called we call end microscopic surgery for the like meningioma or craniopharyngioma. This is not endoscopic, but microscopic surgery you should mention. So finally, we need to coordinate with other divisions in endocrinology and neurology. And that is another important point of this field. Yes. Thank you very much. Thank you for attention.
Thank you for great lecture, Professor Nagatani. This is nice lecture.
Thank you very much.
You talk about evolution of the pituitary surgery from the beginning until advanced surgery technique, including the tool that should be used to have good surgery, and you also explain the surgery for complex tumor at the same time with the transcatheter approach.
Mm-hmm.
There is one question from the participant. It's from my colleague. Dear Professor Nagatani, do you think the use of ICG fluorescent endoscopy to enlarge the opening? Yeah. You can answer it. Directly.
So, but myself it's not so cannot introduce now, but our colleague from Nagoya University introduced, but some technical problems, so we had not. But I very interested in such tools. Yeah, it should be recommended widely. So yes.
So there is no other question from the chat. Yes. I have a question to you. So, why did you do the such difficult tumor at the same time, not in one or two stages? For example, first you have to attack the tumor from intracranial, and then maybe later on you can do transsphenoid. So, what's the urgent indication to do the such difficult tumor at the same time with the crowded people inside the operating theater?
So yes, this problem is very yes, because we have 3 or 4 surgeons, nice surgeons. So we we think the some area can be removed by the from the two direction. The one direction and the second direction. Second direction is can be managed and the seed what he and the another did do. So they can collaborate and to remove the tumor more efficiently, more safely, more yes. So we use this approach, but not so many. Most of them can be one direction, one approach, but some selected case we use this.
Okay, thank you for
not for large size, but a small size we need some, yeah, to avoid the complications. Yes.
Thank you for your explanation. Can I have another question to you? Yeah. Regarding the tools that must be prepared for start doing this endoscopic surgery. So you have any suggestion for those who start doing this endoscopic procedure?
We were very happy to have two companies, so very helpful for us, and so we could create these tools for about 3 or 4 years. Yes, this is very happy, very lucky for us. But usually it's very difficult to create new designed tools, not easy. So nowadays some tools, some dedicated tools for endonasal or extended transfemoral skull-based surgery, endonasal skull surgery can be available. Yeah. So we are very, very happy compared with the early time. Yeah.
Okay. Thank you, Professor Nagatani.
Yeah.
I think there is no any question anymore. And thank you for your great lecture.
Yeah.
And I hope that we can see next time offline and we can talk. Okay, thank you very much for your great lecture. Then
Thank
I
you,
will
Professor Gordon. Yeah.
Yeah. I'll move to another speaker. Thank you.
Yes. Thank you very much.
The last speaker in this session will be Professor Andi. Hello, Prof. Prof. Andi is there? Professor Sadul?
I'm sorry, Professor. Hello.
Hello, yeah.
Yeah, from the committee, want to share a new schedule program for the 5th symposium. Maybe I want to share screen for meanwhile. So there is the new schedule. Last from Professor Tetsuya Nagatani, and then right now we are moving on to Professor Andi Asadul Islam, and then the 5th class from Professor Masao Tambra. Maybe Professor Andi will show in the pre-record video, and so Professor Masao Tambra we will also in the pre-record video.
Okay.
Thank you, Professor.
Can you start now?
Good morning, all of our participants and also all faculty. This time I will present one very rare case, as we got these cases in our hospital in Makassar, Indonesia. This is myelomeningocele and hydrocephalus in my mirror image neonatal identical twin. Myelomeningocele is a congenital abnormality that arises due to failure of neurulation that cause part of the spinal cord to be exposed. The incidence of spina bifida is about 1 till 2 per 1,000 live birth. The risk increases 2 till 3% if the previous birth. Multifactorial family, history of previous pregnancy, parental nutrition, malnutrition for the especially for folic acid, and previous medication, including anti-epileptic. It's a picture of meningomyelocele. Another picture. We have two classification: spina bifida occulta and spina bifida aperta. You can see scheme, spinal dystrophism, open and close, and so on. At this time, we don't talk about the classification. I will talk about the cases. Yeah, this is just image, degree of spina bifida. This picture show us how the meningomyelocele become bigger and bigger. Diagnosis is a neurological exam from the lower extremities movement and evaluate the lowest level of the lesion. Level of spinal T1 till S1, and as we know from, especially for the myelomeningocele, is almost in the lumbosacral level. Prenatal diagnosis is AVP level is 15 and 20 gestation weeks. Ultrasonography 17 to 24 weeks. We can use amniocentesis for AVP level. Postnatal diagnosis is head CT and lumbosacral MRI. MRI be better rather than CT in the lumbosacral. Is one journal, prenatal diagnosis spinal dystrophism by Layat Ben Sira. And this is a picture of prenatal diagnosis with ultrasound. Another picture, prenatal cranial ultrasound, sinus associated myelomeningocele. Management. Patient presenting with a defective myelomeningocele should be closed with 72 hours. It is an urgency from the point of view of the risk of infection or exposure of the neural tissue and leakage of CSF flow. It's become a high risk of meningitis and ventriculitis. The goals of surgical management of open neural tube defect is one, preservation of functional neural tissue, sometimes very difficult. Reconstruction of the dural tube, securing myofascial and skin closure. Sometimes we need to join with plastic surgeon, and also minimizing the chances of future retethering of the spinal cord. Complication, long-term therapy needs to be educated to the family with the possibility of complication in myelomeningocele cases, like infection, hydrocephalus, cherry 2 malformation, tethered spinal cord, and hydrosyringomyelia. This hydrocephalus, a little bit brief, 80 to 90% found in cases of myelomeningocele. It's very high. And then if you get some patient, one patient with myelomeningocele, please do CT of the head, CT scan of the head, because it's about 80 to 90% hydrocephalus. VP-shunt, risk of infection and obstruction. This decreased consciousness for the patient with the myelomeningocele, you should be suspect hydrocephalus. Closure of the myelomeningocele defect is a risk for the emergence of hydrocephalus due to the closure of the CSF flow that previously leaked. Mirror image for identical twin. Twin studies historically have aided to understanding how genetic and environmental factors affect various pathologies. Mirror image pathology in mirror-genital monozygotic twins suggests possible cytogenetic factors involved in the etiology of various medical problems. However, only small case series on mirror image involving the brain have been reported. We only found one journal reported about arachnoid cysts, and no other journals published similar with our cases. It's a very, very special case. It's a case report. 23 days old monozygotic were born by cesarean section. 40 weeks gestation from fourth delivery from a 40 years old mother. Admitted to the hospital with defect of the spine, accompanied by soft mass around it. The complaint had been experienced since birth. Both head also looks bigger than others same age. There was history of intraventricular fluid accumulation on antenatal ultrasound findings. Also, inadequate folic acid intake, history of mother during pregnancy. Illness and medication or herbal taking on pregnancy was denial. First and second gestation were normal births and being normal kids. Third gestation was an intrauterine fetal death. The cause was not clear. Physical finding, twin A, female, twin B, female. Birth of date is 15th of June, 2021. This twin A is twin B. This physical finding, twin A and twin B, both of them have a meningomyelocele with very thin closure, very thin cover. Maybe it says not any more skin. The body weight is about 2,500 grams, heart rate, and so on. Head circumstances 40 centimeters, bulging fontanelle, and erythematous mass in the lumbar vertebral region with epidermal erosion of the middle granulation tissue present. No extravasation of CSF, and debris and pus is present. It's a twin A. It's similar with the twin B. Body weight is lower than twin A. Circumstances, but head circumstances are bigger than twin A. This is why we call it mirror image. This picture of lower extremities. Both of them had from orthopedic surgeon CTEV, but I'm not sure. Maybe because of meningomyelocele. It's a babygram. This is you can see The femur fracture, old femur fracture from twin A is the left side. And then for the twin B, it's the right side. Both of them is old fracture. And we suspected twin A is the dextrocardia. Okay, you can see the chest X-ray. Yes, the other picture. The head scan, both of them with hydrocephalus is about cerebral mantle is more maybe only 1 or below, not just 1 centimeter. It's a spine CT, same CT scan. Okay, spine 3D, very good picture. Diagnosis: communicating hydrocephalus for twin A, like twin B, same rupture lumbosacral meningomyelocell, CTEV bilateral, mirror image, femur sinistra fracture for the twin A, twin B, dextra or right femur fracture. Planning: surgery, phase 1, ventriculoperitoneal stenting for the both, and phase 2, cell excision, defect closing and reconstruction. We also have a chromosome identification, but the result not come yet. This surgery for both. Discussion: 1/3 of twins are monozygote. 25% of them are mirror image. Mirror imaging occurs when pathologic conditions are present on opposite side of the body. The mechanism of mirror imaging is fully understood. And then we have a discussion with pediatrician. They suspected for these cases is Edwards syndrome. Then I would like to get as soon as possible the result of chromosome. It's a trisomy of 13 or 18. It's Edwards syndrome, and they told us it's a very poor prognosis if identical twin diagnosed as Edwards syndrome. I don't have any idea or any experience about Edwards syndrome. Mirroring can be classified as anatomic, functional, medical, or psychological. The mirroring phenomenon is reflection of biological polarization. Previous reports have presented mirror symmetrics in various structures such as headedness, hairward direction, tooth patterns, unilateral eye and ear defect, and even tumor location and undescended testicles. However, only an extremely small series of cases have been published that concern the brain or nervous system. In this case, we found a pair of mirror image monozygote twins with myelomeningocele and hydrocephalus, accompanying with another organs disorder. With this condition were very rare case. In our search, we have not found any references or other similar cases. On first phase, surgery was performed, VP shunting, considering the general condition of the patient and most best outcome of the surgery. Second phase of surgery will perform cell excision and defect reconstruction. To identify the genetic factor, we also did a chromosome identification. For prevention, the women should take a vitamin with 40 microgram of folic acid each day during the years of their lives when they are able to have children. Additionally, women who have a child or sibling with spina bifida, have had an affected pregnancy, or have spina spina bifida themselves should take 4,000 microgram of folic acid for 1 to 3 months before and during the first 3 months of pregnancy. A conclusion, mirror image pathology in mirror image monozygotic twins suggests possible cytogenetic factors involved in the etiology of various medical problems. Mirror image monozygotic twins pathology that involved nervous system was extremely rare case. If an identical twin present with a medical problem, it may be recommended to perform a medical diagnostic workup on the other twin. Thank you very much for your attention. And we hope a lot of suggestion for this case because it's the first case I found and a very rare case. If you have any information about another case, would you please contact us? Thank you very much and see ya.
Thank you, Prof. Sadul, for your great presentation and very exciting case. It's a very rare case. I just heard this case, and of course that there is no idea why this poor baby got this. The poor family got this unfortunate baby. Is there any question from the floor? I have seen on the chart Q&A, there is no question. Prof. Andi may have some question. Prof. Asadul. Hello. Okay. So
yeah. So yeah, sorry. I have one information. I have one information about these cases. There's for chromosome identification, we didn't find any chromosome disturbed. All chromosomes is 46 karyosome. It means this is not Edward syndrome. That's the information just came yesterday or 2 days ago. This very good case, and then I will follow up for both babies. Thank you very much for your attention.
Thank you, Prof. Andi. I think there is no discussion, and I will move to the next speaker. Thank you, Prof. Andi, for your great case, and I hope that you can report this and we can learn from your experience. Okay, next speaker is ready. Is recorded or a direct presentation?
Good morning, everyone. I'm Masao Tambara.
Fukushima Medical University in Japan. Today's my topic is the endoscopic removal of intracerebral hematoma. The efficacy of endoscopic intracerebral hematoma removal is currently controversial, although there are some reports. But however, in our experience, there are often cases that not only life-saving but also show functional improvement. In this presentation, we will introduce our method of endoscopic intracerebral hematoma removal and some of the cases we have performed. When performing endoscopic hematoma removal, hemostasis is often the biggest problem. Therefore, it is necessary to check for any conditions that may cause coagulation abnormalities through blood tests and medical history. It is also important to evaluate the existence of abnormal blood vessels by CT angiogram. Endoscopic surgery requires special instruments different from the conventional craniotomy and microsurgery. In particular, we consider port and coagulation suction tube to be mandatory for surgery. In addition, the surgery for cerebral hemorrhage is an emergency surgery, so we may not be prepared for navigation, but intraoperative ultrasound is very useful to confirm the location of the hematoma. This is disposable transparent port used in endoscopic surgery. It is marketed by a Japanese company. Neuroport regular is mainly used for intracerebral hematoma removal, such as terminal and subcortical hemorrhage. 4 mm and 2.7 mm rigid endoscope can be used. Neuroport Mini is used for endoscopic third ventriculostomy, and interventricular rigid endoscope is also used. The ventricles are narrow, so a smaller port is better. If a larger port is needed, a Bucite is used. Brain pass is not available in Japan. Continuous irrigation can stop bleeding if it is from small vessels. In endoscopic cerebral hematoma removal, one hand holds the endoscope and the other hand holds the suction, so it is not possible to hold the bipolar in one hand. The suction tube in the other hand is as microscopic surgery. Therefore, using a coagulation suction tube makes it possible to perform hemostasis while suctioning. This is a very important tool and is used in the dry field. The coagulation suction tube is coated with an insulation except for the tip, which prevents the endoscope from being charged. If the endoscope is charged, it may shut down, so be careful. Today's cases as below: terminal hemorrhage and interventricular hemorrhage, cerebral hemorrhage, and subcortical hemorrhages. First, I describe the surgery for terminal hemorrhage. If the patient is supine position and make a bar hole about 10 or 11 centimeters cranial to the nasal or hairline, and about 3 to 4 centimeters lateral to the lesion. The skin incision should be straight. If the periosteum here is flap shaped, it is easier to close the bar hole. This is a case of terminal hemorrhage. The patient is a 59 years old man presented with a fatty and severe right hemorrhage. The hematoma volume was 33 milliliters and CTA did not show any spot sign. In this surgery, bar hole is first made on the forehead ipsilateral side, the hematoma, and then drilled and enlarged to the size of less than 2 centimeters At this time, electromagnetic navigation is used. Necrosis incision is made and make corticotomy like this. Its navigation confirms the position of the hematoma and insert it into this is neuroport regular. And this is actually his hematoma. This hematoma is very soft to evacuate. It's very easy. They're almost clear, and after that is a continuous irrigation like this, and you can see here that the perforator, and we can confirm the hemostasis and there is no residual hematoma. After that, we back to the dry field and insert the cell here, hematoma cavity, and put off this and switch the dry matter and put on the Duragen or clogging sponge and then fill the bar hole with bone cement. This is a post-operative CT scan. The hematoma was removed without any problem. The right hemiplasia has improved and the patient can walk. If the pyramidal tract is only compressed, hematoma removal will improve the hemiplasia. This is a high-weight case, and the patient is a 57 years old man who was transported to the emergency room with disturbance of consciousness. He presented with interventricular hematoma from right-coded graves. In this case, we will perform a right anterior horn puncture to remove the interventricular hematoma under endoscopic techniques. The goal is to remove the hematoma from the right anterior horn to the third ventricle and the entrance of the aqueduct, and to place ventricular drain tube after the hematoma removal. This is a case where ventricular drain may be needed bilaterally if endoscopic hematoma removal is not performed. As the puncture is made in the right forehead, ventricular puncture is performed with standing needle from cohort point along the tract of the anterior horn puncture. Neuropotomy is inserted into the anterior horn of the right ventricle and endoscopic observation like this. The first hematoma in the right anterior horn is aspirated and removed until the foramen of Monroe becomes visible under the observation of the rigid endoscope. Then flexible endoscope is inserted like this. Hematoma in the third ventricle is directly aspirated out through the channel of the flexible endoscope. After that, we can see the clearly in the ventricle. This is the ventricular floor. And mammary body is here, and This is aqueduct. The aqueduct is very clear. And this is breathing point. Let's just stop the breathing. And this case is broad septum, like this. And we press ventricular drain like this. This is a postoperative CT scan. In this case, the EVD was removed on the postoperative day, and there was no evidence of hydrocephalus depth. Next, I will talk about cerebral hemorrhage. The patient should be positioned in a semi-lateral position with the head fixed in a horseshoe headrest, so that it faces approximately 90 degrees to the contralateral side. If the surgeon is not comfortable with this position, the head may be fixed with a head pin, or the patient may be placed in a prone position. The puncture site should be below the transverse sinus, approximately at the midpoint of the inion to asterion. After dural incision, intraoperative ultrasound is used to confirm the direction of the hematoma. If the fourth ventricle is filled with hematoma, the hematoma should be removed as well. The patient is 83 years old woman. Although she was elderly, she underwent surgery because her pre-onset LDL was good and her symptoms were expected to worsen due to the large amount of hematoma. The patient is placed in the right lower semi-lateral position with the head turned 90 degrees to the left and the chin slightly down, and the head is fixed. The occipital area has thick skin, so skin incision and the perforator can easily to be safety, so care must be taken. After making burr hole, you should check with intraoperative ultrasound to see if there is a hematoma directly under the burr hole. As long as the burr hole is correct, the hematoma removal itself is very easy, like this. Very easy to remove, like this. And we make a hemostasis using the coagulation, like this. Very easy. The coagulation suction is used in a dry field. In the wet field, we cannot use the coagulation. Confirm the hemostasis and put the cycle. Final view. This is postoperative images. The hematoma was removed without any problems, and in this case, the hematoma in the fourth ventricle was not clear. The burr hole is about in the middle of the inion and mastoid tip, like this. Subcortical hemorrhage is very easy to insert a port because hematoma is extremely superficial. However, in young patients, hemorrhage may be caused by vascular abnormalities such as severe arteriovenous malformation or moya disease, and preoperative CT angiogram is mandatory. In such cases, hematoma removal is basically performed with the aim of lowering ICP. This case is a 50 years old woman who was sent to the emergency room with sudden impairment of consciousness, aphasia, and right hemiplegia. A head CT scan was taken less than an hour after the onset, and the hematoma was still faint, like this. The contrast-enhanced MRI was also taken, which shows a long hematoma occupying the left supratemporal gyrus. There is a contrast effect with the hematoma in the hematoma cavity. It seems to be some kind of abnormal blood vessels. Postoperatively, DSA was performed and there was occlusion of the right middle cerebral artery, which was diagnosed as moya disease. Since the hematoma was cortical and white matter had been destroyed by the hematoma, we decided to remove it from the posterior temporal lobe. For cortical hemorrhages, it is necessary to swing the pot sufficiently, so we made a small craniotomy. It's like a fountain, very high ICP, so it came out. And we use this time also airport regular. Remove the hematoma is very easy, like the previous cases. And this time we take out some vessels, but it's preserved. And we confirm the prosthesis, the continuous irrigation, and tiny vessels must breathing stopped. And also insert the sacil and make the hemostasis. The hematoma has been clean removed. Her right hemiplegia was improved, but her aphasia remains, and she is currently undergoing rehabilitation. For endoscopic hematoma removal, it is important to do the preoperative examination. In particular, evaluation by CTA is very important. It is also important to check for coagulation abnormalities and history of drug use. In order to perform the surgery safely, it is important to always be prepared for the transition to craniotomy. Intraoperative ultrasound and, if possible, navigation are also very useful. Thank you.
Thank you, Dr. Tambara, for your nice and great presentation. Is Dr. Tambara there?
Only pre-record, Doc.
Okay, so there will be no question, yeah?
Maybe any question with the email or commit.
So I think I have already finished this session and earlier than the time that on the schedule. So I go back my time to the committee and conclude this session. Thank you. you have any break or continue to the next session?
Thank you to all speakers for an amazing information and Dr. Nyoman Golden for leading this session. Before we move on to the next session, we are going to take a picture, and to all the participants, please turn on your camera. Okay, for the first slide. 1, 2, 3. Distinguished guests, honorable speakers, delegates, ladies and gentlemen, for the next session, to all participants, please move to the separate hall as we start the satellite session. And to all the participants who won't join this session can choose one of the link provided by the committee on the chat box. Thank you for your attention.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger. All these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
Inject saline into balloon, inflate and deflate repeatedly and slowly. Be cautious during the process of inflation and deflation. If abnormal incident occurs, stop and take remedial measures. Place the tube on the distal part of balloon. Inflate, then push both tube slowly into the tubular corridor. Inflating and deflating appropriately would be helpful.